Good afternoon, good morning, buenas tardes, buenos dias. My name is Terry Camacho Gonzalez, and I work at the Traumatic Brain Injury Technical Assistance and Resource Center. Welcome to this event. Before I start, I want to let people know how to access the live Spanish interpretation. Antes de comenzar, quiero que la gente sepa cómo acceder a la interpretación en español en vivo. Se puede acceder a la interpretación en español en vivo haciendo el clic en el botón Interpretation que está en la parte inferior de la pantalla de Zoom, icono del mundo. Una vez en el canal español, por favor, silencie el audio original. Thank you. So again, thank you for joining us today for the Administration for Community Living Traumatic Brain Injury Partners Day. This Partners Day event is in observance of Brain Injury Awareness Month, which is in March. We are a little ahead of schedule, and it's in lieu of the Administration for Community Living's annual in-person meeting that was previously called TBI Stakeholder Day. We are excited for the opportunity to conduct a virtual meeting for the third year, which will allow more TBI partners to attend. During today's event, we will highlight our federal partners or initiatives, highlight some of the work of the Administration for Community Living funded TBI State Partnership Program grantees, and involve members of the TBI Advisory and Leadership Group, the TAL group. A little background on the TBI State Partnership Grant Program of the Administration for Community Living. It helps states increase access to services and supports for individuals with TBI throughout their lifetime, and there are currently 29 grantees. I actually forgot to introduce myself at the beginning. I'm so sorry. To describe myself, I am a middle-aged Latina woman with dark hair, medium, and I have a green background in the back. I'm sorry. I am so bad at doing that. This webinar, this event is hosted by the Traumatic Brain Injury Technical Assistance and Resource Center, or the TBI TARC, which I work for, and we are funded by the Administration for Community Living. During today's session, you will hear from my TBI TARC colleagues, Judy Detmer and Maria Crawley, and we have other staff that are assisting with this event. This webinar is free and open to the public, and I just want to let people know that it's a long event. It's 4 hours. If you need to take a break, please feel free to take a break as needed, and we will have a break around 2 o'clock Eastern time. And now I'd like to go over some logistics. In listen-only mode during the webinar, please use the chat feature in Zoom to post questions and communicate with the hosts. During specific times, we will have the opportunity to respond to questions that have been entered into the chat, so we'll be monitoring those chat questions. The webinar is being live captioned in English and live interpreted in Spanish. Live captions can be accessed by clicking the CC button at the bottom of your Zoom screen. And live Spanish interpretation can be accessed by clicking the interpretation button at the bottom of your Zoom screen world icon. And once you're in the Spanish channel, please silence the original audio, because then you'll hear like the English. Se puede acceder a la interpretación en español en vivo haciendo clic en el botón Interpretación en la parte inferior de la pantalla de Zoom, icono del mundo. Una vez en el canal español, por favor, silencie el audio original. This live webinar includes polls and evaluation questions. Please be prepared to interact during polling times. After the webinar, you can send follow-up questions and feedback to the TBI TARC at hsri.org. Please note that this email will not be monitored during the webinar. A recording, including a PDF versions of the slides, will be available on the ACL website, acl.gov. We also sent copies of the PDF of the slides early this morning, as well as the agenda and the bios, and we'll be putting links in the chat so you can have access to it. Now, I want to start us off with our first poll question, and we want to know who's here and what roles people identify. And you can select all that apply. The first one is being a person with a TBI or other disability, family member, a friend, or persons with a TBI, self-advocate, a peer specialist, mentor, social worker, counselor, case manager, researcher, analyst, government staff, service provider. We'll just give you some time to respond to the poll. And this is helpful for us to know who our audiences are and what types of people are interested in the event. And we'll just give it some more time. So it looks almost 40% of government employees, and we're not done yet. Over 30% are service providers, 20% self-advocates. We're getting close to 20% are persons with a TBI or other disability. We also have a good representation of family members, self-advocates. Some people identify as peer specialists and peer mentor. Great. Thank you. And now I'd like to welcome Elizabeth Leaf, who's the project officer, one of the project officers for the TBI State Partnership Program, and she works at the Administration for Community Living. And I'd like to welcome her, and she will be introducing us to Commissioner Jacobs. Thank you.
Good afternoon. Hi, thank you, Terry. Good afternoon or good morning, depending on where you're calling in from. Welcome to the Administration for Community Living's 2023 TBI Partners Day. We appreciate your interest in learning more about TBI and the activities being conducted across the ACL and our TBI networks. My name is Elizabeth Leaf, and I am one of the project officers assisting the TBI State Partnership Program. I share these responsibilities along with my coworker, Mr. Sean Calloway, who you will hear from later in this presentation today. But right now, I have the pleasure of introducing Ms. Commissioner Jill Jacobs from the Administration for Community Living. Jill Jacobs was appointed as a commissioner back in February 14th, 2022. And she has managed more than 2 decades of professional experience managing disability services organizations, analyzing policy, and working towards improving health and disability programs and services at all levels, state, local, and federal. Ms. Jacobs brings us her lived experience of life with her own disability, and that as a mother of 2 disabled adults. Because of these experiences, she's had to be an active grassroots organizer most of her life. In addition, before joining ACL, Ms. Jacobs served as the executive director at the Independent Center of Northern Virginia, which is one of the first centers for independent living in Virginia. Ms. Jacobs is passionate about her work in disaster preparedness, and new initiatives are being developed in partnership with FEMA that will ensure people with disabilities are not forgotten and their voices are heard. Lately, Ms. Jacobs has been traveling around the country in collaboration with CMS to visit HCBS living sites and institutions for heightened security visits. During these visits, she has uncovered policies that were on paper, but not implemented in practice. This is another high priority to the Commissioner and ACL to ensure people with disabilities and the aging continue to have their basic human rights upheld. Jill's full bio is available in the PDF that you received in the agenda. So please help me welcome Commissioner Jill Jacobs.
Hello, everybody. First, I would like to describe myself. I am a white woman. I'm sitting in my home office. There's some artwork behind me. I have glasses and brownish red, always messy hair. I'm wearing a black sweater and a blue shirt. And I'm middle-aged. So it's very nice to see you all today. I want to say that I think this is the second time I have spoken to you all. When I very first came on board, this was the first meeting I spoke to. So Success, second time around. So welcome everyone to this wonderful event. I know that last year at the event, there was more than 600 participants that had registered for the event, and we had almost a 70% attendance rate. So that's pretty awesome. And this year is even larger. I just want to talk real quickly about our work, what this work is. I've just got a few minutes, so I'll be quick about it. But I do want to talk about this, and that this is a growing program. Our TBI work is growing. We are growing the sorts of work that is being done across the country. Our work is done through states, and then states reach down, statewide to make sure that services for people with TBI and their families, their caregivers, that all that happens. We currently have 29 TBI grantees, and as I said, we're always looking to grow. And South Carolina is our newest grantee. A huge part of the TBI work is collaboration, and collaboration is a really big part of what we aim to do at ACL. So I love to see that the collaboration happens within our network and across our networks. And so a good example of TBI collaboration is Georgia and Alabama, for example. They have worked together with the PNAs, those two states, with the PNAs and the TBI programs to address issues like behavioral health management. We love to see that kind of thing happen. Did you know that this past year, TBI programs have reached out through screenings to 17,972 people. There have been almost 18,000 TBI screenings through our programs. And did you know that we focus on training across the country? All programs are a little different, but we've got training focused on we've got programs focused on training physicians, EMTs, and other clinical professionals and medical providers. We have training and support focused on family, friends, and caregivers of people with TBI, on training and supporting university staff, primary and high school and junior high school staff, veterans and military, members of law enforcement. So this is really, really important work that we're doing. As we know, oftentimes, most of the time, the biggest problem that we face when it comes to inequity is the rest of the world not knowing what we're about. Just not understanding, and therefore not knowing how to interact with us in ways that are equitable, safe, fair. So that's a really big thing. All that training and support that's provided helps to make the lives of people with TBI better. So I'm really proud of that. In the last year, there's been 17,100 informational and referral contacts in the last year, which I think is pretty fantastic. If you think about that, that's more than 1,000 a month, 1,200 a month. That's impressive, y'all. So this year, this is going to be an exciting conference. There will be sessions on aging, employment, intersectionality of TBI, medical and social issues, peer support, one of my favorite things to talk about, peer support. So you should have an agenda available to you. There's more than 600 people registered, great professionals, great peers, are going to be speaking, and I hope you all truly enjoy the conference. And I want to thank you all for the work that you do as professionals, for your willingness to participate as people with TBI, family members, and support people. We know that the real stakeholders are people with disabilities, and we always appreciate and value all the work that professionals do as well. And we keep focused, however, on you all, people with disabilities that are here working with us and helping us to understand what really is most important. So thank you again for being here, and have a great conference. Bye, guys.
Thank you so much for that nice introduction. Sorry, Elizabeth. I think I jumped right on top of you there.
That's fine. Take it away, Judy.
Okay, great. We appreciate you being here, Commissioner Jacobs, and thank you for that great introduction to the conference today. My name is Judy Detmer, and I wear glasses. I have shortish blondish hair, have a gray sweater on, and a couple of vintage posters behind me. It is my pleasure to introduce our first session, and that is a session on aging. And today with us, if you both could pop on screen, we have Edwin Walker. Edwin Walker is the Deputy Assistant Secretary for Aging, at the Administration for Community Living. And then Dr. John Corrigan. And most of you are aware of who John is, but he's the director for the Ohio Brain Injury Program, and he is one of the Traumatic Brain Injury State Partnership Program grantees. And they are going to be talking today about aging. I'm going to let them go ahead and get started. Just know, as we said earlier, full bios are available to you. We didn't want to take a lot of time to do major introductions when you have that available to you. Edwin, I'm going to let you take it away.
Great. Thank you so much, Judy. And it's my pleasure to be with you all today. As indicated, I'm Edwin Walker. I'm an older African-American male with gray hair, a little bit of gray hair, and a beard. I'm wearing a brown suit, a yellow shirt, and an orange Noah's Ark tie. And I'm in my office with flags and photos all behind me. Could we go to the next slide? Thank you. I was asked to talk a little bit about aging, and I thought I would start with the Administration for Community Living, which I know many of you all know, but just as a refresh, we were created in 2012 by bringing together aging and disability components throughout the Department of Health and Human Services. And then we were so pleased that other components were also transferred here because of the aligned mission and vision. And our mission really is focused on maximizing the independence, the well-being, and the health of older adults, people with disabilities across the lifespan, as well as for their families and caregivers. And we all have that vision that all people, regardless of age and disability, live with dignity, make their own choices, and participate fully in society. Next slide. For purposes of aging, 1965 is a critical year that I would want you to just remember. That year, 3 important programs were enacted, and they were part of a 3-part strategy of President Johnson to combat the war on poverty, because at that time, older individuals, many lived in poverty. They didn't have access to hospitals or physicians or healthcare. And so he created, all in July of 1965, Medicare, Medicaid, and the Older Americans Act, designed to complement one another and to provide those types of services. Next slide. The Older Americans Act, which is our primary piece of legislation, has 7 titles, and I'm going to cover them to give you an overview and to describe what we have in this country as our infrastructure for aging programs and services. Title I is the title, it's called the Declaration of Objectives, and there are 10 of them. And so we tend to think of them as the Bill of Rights, the 10 Bill of Rights. They are aspirational. They speak to what we believe older people should have in this country. They should be able to enjoy life. They should have access to good health. They should have access to housing and be free from abuse, those kinds of things. Title II actually establishes the Administration on Aging and what we refer to as the National Aging Services Network of state units on aging and area agencies on aging and national service providers throughout the country. Title III is our state program title. It's the formula grants to states. And we give money to states basically based on the number or the percentage of people over the age of 60 who reside in those states. And it has a number of subparts. Title IIIB is supportive services in senior centers, and I'll talk about that a little more. Title IIIC is nutrition services, which most people know us for. Title 3D is disease prevention and health promotion, and Title 3E is our National Family Caregiver Support Program. Next slide. Title 4 is our discretionary projects, where we fund program innovations and training and demonstrations, and we think ahead in terms of what we believe is needed in the field of aging, and we then fund these projects to develop and test ideas, and then we institutionalize those ideas by making them part of our national programs throughout the states. Title 5 is the Community Service Employment Program. It's the only part that is not administered by the Administration on Aging. It's administered by the Department of Labor, and it's also the only portion of the act that is means tested. It's designed for low-income seniors, 55 and older, with limited prospects for employment. And it's designed to provide them training opportunities to get them back into the workforce and to keep them out of poverty. Title 6 is our programs for American Indians, Alaska Natives, and Native Hawaiians. And Title 7 is our elder rights protection programs. Let's go to the next slide. This slide is what we refer to as a depiction of the National Aging Services Network. As you see, under the Older Americans Act, we serve about 11 million seniors, or about 1 in 5 in the country. And we do that through low-cost community-based programs. And it's a great value because for every $1 in federal funds that we provide, it generates another $3 from state and local communities and older people themselves. But this depiction shows that the Administration on Aging is at the top as the federal entity, and we provide guidance to states. We're not a compliance-oriented entity at all. We actually work in partnership with states and tribes in this national network because our goal is to ensure that we're all successful on behalf of older people. And so states then designate area agencies on aging as regional entities within their states, and then they contract with over 20,000 service providers and have hundreds of thousands of volunteers who provide their time and their energy to develop the services and supports that you see at the bottom of the screen. Next slide. In the Older Americans Act, it's not like Medicare and Medicaid because it's not an entitlement. It is subject to annual appropriations by the Congress. As a consequence, it hasn't grown like Medicare and Medicaid and is very small in comparison. But it has a broad mission. It says any person over the age of 60 can participate in these programs. But because it's appropriated funds, it's targeted. And so it assures that there's a preference given to those in greatest economic need and those in greatest social need, with particular attention to low-income older individuals, low-income minority older individuals, those with limited English proficiency, those residing in rural areas, and those at risk of institutionalization. And these generally are the categories of older individuals who have had difficulty or been denied access to services and supports. And so the prioritization is built into the statute so that we try to ensure that they get outreach, access, and services. Next slide. To give you a sense of who we target, this slide focuses on who we serve. And we really target the poor and the near poor, those who are frail and vulnerable, and you see how we define that: people who live alone, people who have diabetes and heart condition and other chronic conditions, minorities, those in rural areas, and those at risk for both emergency room visits and hospitalizations, as well as at risk for nursing home admissions. Those are the folks we target to help them stay in their own homes and communities as opposed to being institutionalized. Next slide. We really focus on the issues of health and independence. That's what we try to maintain for older people in the community. And we do that through our home and community-based supportive services. And this slide just shows you the array of things and a couple of examples. For instance, we provide adult daycare and case management and information and assistance to connect people with services in the community. We also provide evidence-based interventions that have proven to maintain health, improve health, prevent falls and injuries, and just allow individuals to live a productive life in the community. As you see on the right side of the slide, where I have transportation as an example of who we target, you see that more than half of the people that we provide transportation services to rely on our service for the majority of meeting their transportation needs. And you also see that 14% of our transportation riders take 10 or more daily prescriptions, and so they would be a safety risk if they were driving. Next slide. Also in the area of health and independence is our largest health-related service, nutrition services. And there we have 3 distinct programs. Our congregate program, which is meals in group settings, such as in senior centers, our home delivered meals program, which most people know of as Meals on Wheels, but it's for frail seniors who are homebound. And then the nutrition services incentive program, which we received from USDA, and now we administer it, but it rewards states based on an incentive which is based on the total number of meals that they served in the previous year. So each state gets a percentage of their share. But the main thing here is to just acknowledge the connection between nutrition, good nutrition and good health, and maintaining functionality and the ability to remain in the home. You'll see on the slide that 60% of our home delivered and 52% of our congregate clients indicate that the meal that we provide them represents half or more of all the food they get for the day. And 9 out of 10 of our home delivered meal clients reported that the meals that we provide actually help them continue to live in their own home and community. I know I'm running through these slides rather quickly, but I understand that they've been provided for you. So I would ask you to go back and look at all the data on the slides as we go along. Next slide, please. I mentioned our caregivers. It's important to talk about our support to caregivers because 80 to really 90% of all long-term care is not provided by some publicly funded service, but it's provided by family members, friends, and neighbors. And in the year 2000, we realized that it would be a wise investment for us to support those caregivers and allow them to continue to do what they want to do, which is to provide support to their loved ones. It's important to know that 85% of the caregivers that we're providing services to have indicated that without our services, they would most likely have had to put their loved one in a nursing home or assisted living. And it's a wise investment because, as you see the third bullet on the right side, the value of this caregiving, if we were to try to pay for it, exceeds $522 billion annually. That's something we just simply could not afford. So it is a wise investment for us to provide supports to caregivers to enable them to continue to provide care to their loved ones. Next slide. Title VI that I mentioned is our program for American Indians, Alaska Natives, and Native Hawaiian programs. It basically replicates what occurs with the states. So they have a series of programs focused on nutrition and supportive services, as well as caregiver services. The big distinction is that the funding is just not even close to what it needs to be. And so we work collaboratively with the Indian Health Service and coordinate health services with our health-related and supportive services to enable tribal elders to remain in their own homes. Next slide. Title VII is our protection of vulnerable elders programs. There are 3 of them. First, the Long-Term Care Ombudsman Program, which provides training and education and certification for volunteers and staff to go into facilities, long-term care facilities, whether it's nursing homes or assisted living or boarding care, to monitor the conditions, to investigate complaints, but really to represent the interest of the residents above all others, above administrators and above family members. And it's an incredible program that we just honored to have. We also focus the second program on the prevention of elder abuse, neglect, and exploitation, and we operate this under the Older Americans Act in coordination with the authorizations that we've received under the Elder Justice Act, which was passed in 2010. And then last, we have legal services, where we're the second largest funder of legal assistance for the elderly following the Legal Services Corporation. And here you see the top areas of legal assistance where we assist people maintaining their income and ensuring income security. We help them access healthcare. We avoid evictions from their housing, and we focus on consumer protection, and we also prevent elder abuse. Next slide. Generally, people don't even think of us until there's a crisis. And what we find is that when family members have long-term care needs and they look for help, and what they find is this maze. It's confusing. It's the long-term services and supports puzzle. Where do I go for help? And so within the Administration for Community Living, we developed the concept of no wrong door, whereby we are empowering and educating and providing information to every touch point so that they each can provide the services and not say, oh, I'm not the right agency. You have to go here, you have to go there. So we took this puzzle and we are working to ensure that there are no wrong doors when you attempt to access long-term services and supports. Next slide. Under the Older Americans Act, it requires that area agencies on aging develop comprehensive and coordinated service delivery systems. What this means is it doesn't matter that we don't fund or that we don't fund area agencies to provide these services. Regardless of the funding stream, they are to know what services exist in their communities and have partnerships and connections with those entities so that if an older person needs those services, they can make adequate referrals, appropriate referrals to them. So as you see on the slide, the array of other entities and organizations and services in the communities that area agencies on aging coordinate with in order to develop this comprehensive and coordinated service delivery system. Next slide. When we tend to talk about who we serve, people generally pigeonhole us and think that we only serve seniors. But I wanted just to highlight for you that we are serving seniors, family caregivers, Medicare beneficiaries, Medicaid eligibles, dual eligible individuals, people who reside in nursing homes, middle-aged individuals who are planning ahead, as well as younger people with disabilities. Next slide. And while I've given you or tried to give you an overview of our programs, lastly, I wanted to highlight some opportunities for collaboration. Certainly, when I think about TBI programs and our programs, I think that we can truly collaborate with the core home and community-based supportive services that we have, transportation and information and assistance and connecting you to supports in the community, that array of other services that exist. We have a number of falls prevention demonstrations, and they're focused on avoiding falls and addressing fall risks, as well as addressing the fear of falling. We also have falls prevention core funding that goes to every state, not just the demonstrations that test innovations, but the falls prevention money that goes to every state to incorporate in their normal program and to provide supportive wraparound services for. We provide those caregiving services, and I think that there's an opportunity for us to collaborate with regard to the caregiving services we provide, the knowledge we've gained. We've done that with the Veterans Affairs Department, where we have a number of programs focused on supporting veterans who did not want to, younger veterans in particular, who came back from the wars, did not feel they fit into the institutional structure of the VA and wanted support at home with their families caring for them. So we've provided information to them. And I think that we can collaborate in that regard as well. And then in the area of our Alzheimer's and other dementia programs, and as well as our brain health programs, we are focused on developing dementia-friendly systems of care so that entities throughout the communities know how best to provide care in a dementia-friendly way that takes into account in a sensitive way the issues and concerns of family members and people who are experiencing dementia. And so we're spreading dementia-friendly interventions and the know-how throughout the country. And then last on this slide, I've noted the national strategy to support family caregivers. Under the Raise and Supporting Grandparents Raising Grandchildren Acts, we had the honor of hosting 2 advisory councils, and they developed, with the help of their members who were professionals, family members, caregivers, and the like, a national strategy to support family caregivers with over 300 different interventions and recommendations for both the public sector and the private sector. And we would ask you to join with us as well in looking at those strategies in order to think about how best to implement them. The last thing I would mention is that we are also sponsoring on May 11th for Older Adults Mental Health Awareness Day, a virtual event that will, and we have a session focused on TBI and older adults. And we're exploring how traumatic brain injuries impact older adults and their mental health. So we will provide additional information with regard to that. We hope that you sign up for the ACL e-newsletter, because we have information there and registration information for you to join us on that day and learn and participate. So I want to pause here. Thank you very much for the opportunity, and I await your questions at the end of the next presentation.
Thank you so much for that presentation. And if we could have Dr. Corrigan please come up and present.
Thank you, Judy, and thank you, Edwin, for that excellent overview of the Older Americans Act and ACL's programs in aging. I'm John Corrigan. I'm an older white male with gray hair and glasses. I'm wearing a white shirt and a beige sports jacket. I'm sitting in my office with a bookshelf over one shoulder and an abstract painting over the other. What I'm going to talk to you about today is a very narrow and specific program that occurs in Ohio. And I will just warn you in advance that I'm going to be showing you some data because I often I need data to understand things. And so I'm going to ask you to share in that. And what I'll be talking about is persons with traumatic brain injury who contact Ohio's No Wrong Door hotline. Edwin mentioned the No Wrong Door process. If you do, next slide, please. And one more. In Ohio, when we, with our Balance Incentive Program, we initiated this No Wrong Door single entry point hotline, which was intended to have one place where all inquiries regarding supports people needed, questions they had about ways they could get assistance to stay in the community. Next. The hotline is primarily administered by our area agencies on aging that Edwin noted, but there are other nodes that include independent living centers and some other nonprofits. And next. It's a computer-assisted interview, and besides just kind of registering basic demographics, and then going on to helping a person identify or navigate needs, it also has a portion that tries to assess other needs that a person may have beyond just the ones they're calling about. And one more. And it launched in October of 2017, and we had the good fortune due to some good collaborations within our Ohio Department of Aging to have a very brief screener for lifetime history of traumatic brain injury added into the assessment portion. Next. And one more. So what that screener does, it's very brief, and the lead question is it asks people simply if they've been knocked out or lost consciousness as a result of any injuries that they've had in their lifetime. If they say no, it stops there. That's the only question asked. But if they say yes, next, then they're asked what was the longest time they were knocked out or unconscious. And there are three choices there that are selected by the interviewer. And next. And finally, the third question, which is a little off my screen, but it says, how old were you the first time you were knocked out or lost consciousness? And their age is recorded there. So this is a very brief screener. We know that when a screener about lifetime history of traumatic brain injury is this brief, that it runs a risk of not identifying everybody who has had a traumatic brain injury. In particular, that if there's no opportunity to really be reminded of injuries previously in your life, then, or times you went to the emergency room, for instance, then you might forget about reporting an injury that occurred, particularly in the remote past. So knowing that, and if you go next, what you see here is that we are only capturing with this screener part of the continuum of traumatic brain injury severity. So where the arrow there is in the middle saying any loss of consciousness, we are capturing the injuries from there on out to those more severe. But we are not capturing some of the injuries that only occurred, only caused someone to be dazed or confused or have a gap in memory. So that's at least two ways in which we know that the individuals we're capturing with this screener may not be all the individuals who've had a traumatic brain injury. Next. So, and next. So this, the program started in October 2017. We have data, actually we have now data through August of 2022, but didn't have time for this presentation to add that. There have been 65,000 callers who were given the assessment portion of the hotline, in the hotline call. Next. The vast majority are 60 years of age and older. 3 out of 4, 75% are 60 or older. Next. But a first caution, one of the things we found is that approximately half of the records from these calls, the caller did not receive the assessment, not just our screener, but didn't receive any of the assessment items. So that means that there's a portion of this we don't know. Are these return callers? Was this a second follow-up call? And so it didn't need to be done. Those kind of details aren't known, but it makes us a little bit cautious about interpreting the data. And next. More caution is that that the method for reimbursing providers, primarily the area agencies on aging, but others, for doing staffing the hotline, the method of reimbursement changed. And next. And one of the things that happened with that change is that it incentivized more assessments being administered, which was good. But next, from at least an epidemiologic point of view, not good was that what we saw was as more assessments were administered, the number of people identified with a history of traumatic brain injury increased, which may suggest that if to some degree, whether the assessment was, at least the brain injury assessment was given based on the interviewer's suspicion of a brain injury, then that they may not have suspected one as often as they needed to. So with these cautions, let me show you something next. In Ohio, we also have a statewide population-based survey through our behavioral risk factor surveillance system that provides us with the prevalence of lifetime history of traumatic brain injury for all non-institutionalized adults in the state. And you see that in 2018 and 19, which roughly overlaps with a good part of the data here, 15% of adult Ohioans had at least one traumatic brain injury with loss of consciousness, that's what LOC is, sometime in their life. The callers to the No Wrong Door hotline, it was some 16%. And while you might think, well, that's pretty equivalent, that's good, we would actually expect more callers of the callers to the No Wrong Door to have had a history. And there, when we break it down by age, you see under those who are 21 to 59-year-olds, that indeed, that's what we're seeing, that while that's 16% of the Ohio population in that age group have had a TBI with loss of consciousness, 28% of our callers in that age group reported one. For those 60 years of age and older, it's about the same. It's both at 12%. Again, we would expect that to be higher rather than 12% for those callers to the No Wrong Door hotline. Probably, I would say 15 or 16 or 17% would be more my expectation. Next slide, please. So the question is, and next, what utility does this screener have, given there are some of the weaknesses I pointed out? Well, first, you would not want to use it for epidemiological inference. In other words, if you're trying to say what percent, what's the prevalence in the Ohio population, not a good use of these data. Next. But it can be used to examine the frequency of callers who are using the hotline. Whatever they represent in terms of the population, we know these individuals called. And next. And then among those who call, we can look at any unique needs that are associated with having a history of traumatic brain injury, because we have a good portion of individuals who report no history, and we have a good portion of folks who do. And so what I want to do with most of the rest of my time is show you some of the data that came from comparing those who had a history of TBI and those who did not. Next. The period we're going to look at is the period where after the method of reimbursement had changed. So we're just looking at March 2020 to August 2022, the most recent data actually. And these are some 28,000 callers were assessed during that time. Next. I think one of the most important numbers I'm going to show to you is this one, that 37 callers per week have a history of TBI with loss of consciousness. And remembering again that our screener has a tendency to under-identify. And next, 9 callers per week had at least one moderate or severe traumatic brain injury in their lifetime. And what we know that when a traumatic brain injury is at least moderate, if not worse, that the likelihood that it is affecting you today in some way, it may not be causing disability, but it may be affecting your thinking or behavior or motor function in such a way that you have unique needs as a result of it. Next. So one of the things, and I'm going to show you several graphs like this, I'll orient you to it. This is looking at people on Medicaid who call in, whether they are on Medicaid or not. And what we're looking at is at the far left of each graph is people who report no history of TBI with loss of consciousness. And then each of the 3 columns after that are whether the worst TBI that they reported was mild, whether it was moderate, or it was severe. And on the left there in blue, what we see here are the percentage of callers who reported being on Medicaid. And you see that it's about half of those who did not report a history of traumatic brain injury, but with successive greater severity of a history of traumatic brain injury, that percentage goes up to where it's 3/4 of those with a moderate or severe. On the right is essentially a statistical calculation that is accounting for age differences and saying what is the likelihood, given you've had a traumatic brain injury of each severity, that you are on Medicaid. And what you see there is that there is statistically significant, that's what the dark red means in this case, that it's a statistically significant greater likelihood, almost twice as likely with a mild TBI with loss of consciousness, but 3 or 3.5 times more likely that you're on Medicaid if you had a previous history of moderate and severe traumatic brain injury. These data, by the way, have been of special interest to our Medicaid managed care organizations in Ohio. Next. People are asked about their activities of daily living and the needs they have. What you see is a lot of callers have needs around activities of daily living, some anywhere from 80 to 88 to 92%. And despite the fact that that doesn't leave a lot of variance to be predicted, still the odds that you have such a needs are statistically significant if you had a history of traumatic brain injury, and those odds were greater generally as that severity of injury increased. Next slide. These are some selected specific activities or areas of need that individuals who said yes they had a need, then they were asked what specifically their needs were, and in all cases the persons with a history of traumatic brain injury, these kind of orangish bars, were more likely to endorse the specific need than those with no TBI history, the blue bar. Some of these percentages aren't that different, and you may have a little difficulty reading those middle bars, but they represent a variety of needs. It's not just around cognitive problems necessarily, but they also include motor problems as well. Next slide. For instrumental activities of daily living, it was even more pronounced. Almost 98% or more of callers are saying they have some need around instrumental activities of daily living. And that's so high that you can't really predict any variance. There's no variance left to predict. And so all of those relationships on the right are non-significant. But next slide. Some of the specific areas of in terms of instrumental activities where needs were expressed. In all cases, again, the persons with a history of traumatic brain injury were more likely to express the needs, and you see it ranges from managing money to phone making calls, or over on the far right, shopping for groceries, clothes, or household items. Interesting to me are in the middle there, opening food packages and cutting food. I don't know that we would have predicted what might be guessed is a motor limitation would be so much more prevalent among those with a history of traumatic brain injury. And that's the kind of unique finding that will be leading us to kind of dig down further and try to figure out just exactly what we're seeing. Next slide. People are asked whether they need assistance taking their medications, and some 70% of those without a history of traumatic brain injury say yes, but you see that as you have a history, that increases up to 78% of those more severe. And then over on the right, anywhere from 15 to 50% more likely to require assistance taking your medications with a history of traumatic brain injury. Next. Very pronounced differences in terms of needing assistance in seizure management. So this isn't just having the seizure, but seeking assistance, needing assistance in seizure management. You'll see it's 1% of those with no history of traumatic brain injury, but depending on the severity of your worse, it can increase up to as much as 9% of those who've had a severe traumatic brain injury. And very low very high odds that when accounting for age, that one will express needs for seizure assistance and seizure management with greater severity of traumatic brain injury, with that severe group needing 8.5 times more likely to say that they needed that assistance. Next slide. One other area asks about skilled nursing services or assistance. This is anything from suctioning to assistance with wounds or suturing or other things. You see a very marked increase amongst those with a history of traumatic brain injury, expressing they need that need, 24% of those without versus almost 45%, 40 to 45% of those with a history. And again, on the right, you'll see that as one's severity of their worst injury increases, then that need increased. One last of these graphs, thank you for obliging my data needs here. This is a little different kind of question. These are two different scales that are administered. On the left in the yellow is the CAGE, which is used to assess risk of alcohol addiction. And on the right in the green is the Kessler psychological distress, which gets at as it says, the presence of distress. And once again, what we see here is that those with a history of traumatic brain injury have elevated scores, and these are statistically significant differences, and in both for addiction, alcohol addiction and psychological distress. That's when compared to those with no such history. Okay, no more data. Let's just talk about it for a moment and I'll wrap up here. So next slide. I put this one back up because again, I think it's the bottom line. You know, what we've seen here is that there are differences in terms of the needs of callers who do or do not have a history of traumatic brain injury. What I would suggest to you is that maybe that some of those differences in the types of needs are not that great. But the thing I would assure you is that the ways in which those needs need to be addressed is different for many of the people with a history of traumatic brain injury, particularly those who've had the more severe traumatic brain injuries. And so, you know, if we're looking at you know, talking with somebody about helping them manage a checking account, for instance, if the history of brain injury has affected cognition or other things, we need to be aware of, you know, a person's attention span. Is this a good time to be trying to teach them something new? Are they able to listen? Are they in the distraction-free environment when we're trying to do that teaching? Are they understanding what we're saying? And so, you know, it may not be the need itself that's so different, but the way in which the need is addressed. And that what we are seeking to do as part of the Ohio Brain Injury Program is have workers in all our systems, but particularly in this case, in the systems that work with people with older adults, have them educated enough that they can identify that a person's had a history and then be kind of neurologically informed so that they can be thinking about what it is they're trying to do or communicate with an individual in the context of are there impairments or weaknesses here that I should be aware of? And you know, how important is this? Well, 37 callers per week is about 1 in 6 calls into our No Wrong Door hotline. 9 callers is like 1 in 25 or so. So this is not a one-off. This is every day in terms of our No Wrong Door hotline. A little bit more about what we're doing in Ohio, if you advance. And again, we use an approach to systems change that we call NETS. It's called Network Engagement, Training, and Support. And then the first step is we try to identify existing healthcare or social service systems that are serving persons with brain injury. In this case, we're talking about older adults with brain injury. And the starting point is they may or may not know whether they are serving persons with brain injury, but we have identified that that's so. And next. And our first step is to try to engage the leadership regarding the need to increase their staff awareness and competence for working with persons with brain injury. And so often it might include, something like the data I showed today, which says you are working with folks, whether you know it or not, who've had a brain injury. Next. We then seek to provide training to raise staff awareness and even more important, to give them some skills on how to identify whether the person they're working with has had a history, and some skills around how to accommodate basic needs, particularly those associated with cognitive problems or problems around so-called neurobehavioral problems. And one more. And then not just go in and train and expect that to make a difference, but to continue to support staff via consultation. So if they have somebody particularly difficult that they want some help with, or they have somebody that they could that would benefit from essentially having parallel involvement with our resource facilitation team, that the staff can seek that consultation. And that we then provide ongoing training for new staff, as well as new information about brain injury. Again, next. So some of the partnerships around serving older adults in Ohio that we've developed is first through our Aging and Disability Resource Network. We call it a network, the ADRN in Ohio, which is primarily our area agencies on aging, but also our independent living centers. And in both those systems, we have been successful in reaching out at the leadership level. And I would say we have had penetration down into some regions or specific centers, but I wouldn't call what we've done comprehensive yet. We have had the good fortune to have a long-term relationship with our Ohio Long-Term Care Ombudsman Program, which Edwin mentioned is one of the services under the Older Adults Act. In this case, I would say that we have done much better in terms of engaging, and we are now part of the onboarding of all new staff. And we regularly receive calls for assistance, requests for assistance from ombudsmen across the state who are working with individuals they've identified as having a history of brain injury. I would say, unfortunately, fortunately, that a lot of that success was from the insight of Bev Laubert, who ran Ohio's long-term care ombudsman program for years. But in the meantime, ACL stole her away to run the program for the entire nation, and they got somebody very good. And finally, and I alluded to this, but an area of penetration in terms of this nets or making systems change that we think has great opportunity for making a difference is in our Medicaid managed care organizations, where many of the individuals who do have Medicaid or are dual eligible Medicaid, Medicare, are receiving their health care, and as well as in some cases their home and community-based services. So we have been at this for a while in Ohio. I would like to tell you that just putting in a screener and the rest, then it all happened automatically after that. Not true. As everyone who does systems change knows, it's a long slog, and we are still slogging. And I will stop there, and I think we still have time for some questions.
Thank you so much, Dr. Corrigan. Such great information. Whew, there's a lot of questions and chatter going on in the chat, so I'm trying to keep up. But while I have you up here specifically, there were several comments about screening, and I'm wondering if you can talk, because I know you've done a great deal of work in this area, talk about how you accounted for poor recall, and there's a lot of comments about screening in itself is inherently challenging when you're talking to people who have brain injuries in terms of their ability to recall, et cetera. Can you talk a little bit about your method in how you ask those questions and how that tool is designed specifically to address those concerns?
Sure. And some may have recognized that this is kind of a subpart of a larger tool called the Ohio State University TBI identification method that we use in a lot of places. But for the No Wrong Door, we didn't have time to do the whole screener. And so we had to pick a subpart. And there's no question that when you try to be fast, you're going to miss more. And particularly what you're going to miss is less severe injuries more remotely in people's past. And so we kind of know that that's a weakness of what we're doing. And, we try to make up for it in other ways in terms of, training the area agencies on aging, how to do more thorough screening, et cetera. Screening, what this is a retrospective self-report is this kind of screening is not perfect, but what it does accomplish generally is that the weakness is in less severe injuries in the past. So more severe injuries, even if in the past, or less severe injuries more recently, are more likely to be reported. And those are also folks who are more likely to have needs. And so we think we're hitting the sweet spot, even though we know we're not being perfect.
That's great. Thank you. And then just if you could comment a little bit about the so what. So screening to understand if someone had a brain injury, now what benefit does it have for the person? Someone was asking, what do you do with the information, et cetera?
So in our case, in the No Wrong Door, then that is flagged as that record goes on. If that person is being referred to their area agency on aging or to their independent living center, then that information is going with it. It's a yes. Now, if in the process of the actual call they ask for information, then they're referred to the INR helpline of our Brain Injury Association of Ohio. So they have that information immediately, but that they are a positive screen goes with them to the next step. And that's why, the systems change is not just getting a screener in there. The systems change is that our area agencies on aging, our independent living centers are themselves neurologically informed and understand how to accommodate the unique needs of brain injury when they're serving someone.
Great, thank you. I'm going to switch gears just a titch because this question is sitting in front of me right now and it's an interesting question. So someone asked, have you, and this is, I don't know, for both of you perhaps who have an understanding of this program, have you encountered a state that has ombudsmans for brain injury waivers or only long-term care waivers? And then they went on to say, in Vermont, we find that having an ombudsman would really be beneficial, but can't utilize the service. So are ombuds programs specific to a certain disability, or do they go cross disability? Can you speak to that?
Edwin, do you want to take that first?
Sure. Under the Older Americans Act, the Long-Term Care Ombudsman Program is specific to long-term care facilities, and they attempt to address any issue that they encounter in a facility on behalf of the resident. So no, the answer to that question is no, I'm not aware of an ombudsman program for brain injury waivers or just long-term care waivers.
And
yeah,
sorry.
Go on.
And thus in Ohio, we train all our ombudsmen in all 88 counties to be able to understand what brain injury is.
Great. And then we have maybe 2 more minutes left. Early on, someone had asked a question about outreach, and if you have any insight or strategies about how to be effective with outreach. And John, when you were talking, they added to that question to say, how do you even get people to a hotline? How do you get them to a helpline? How are we reaching our general population with outreach? Any strategies that you can offer, either of you?
Edwin, I'll defer to you first.
Yeah, I think my response is informed by what we've gone through with the pandemic, where we were trying to conduct outreach to individuals to actually get them to a vaccination, to the point of getting a vaccination. And what we found is that it is very localized. Your outreach has to be targeted to the populations that you're really focused on in your community. You have to have a trusted community organization or a trusted individual to be effective in conducting adequate types of outreach that will be influential in getting a person from point A to point B.
And it needs to be a constant effort. You don't just stand it up and say, there it is, and walk away. And, you have to constantly be keeping the presence of a hotline or related, outlet like that in front of the public, because otherwise they forget. The proliferation of 211s, has helped that to some degree, because then you just need to make sure that whoever's answering the 211 line is aware of all of the other resources. But 211 is not widespread or widely used yet. So I think it's still a challenge before us to get the awareness of that front door, as well as making sure it's not the wrong door that somebody knocks on.
Great. Thank you both so very much. We are at time. I know there's more questions, so we'll try to answer some of them in the chat if we can. But really appreciate your presentations, very informative. And with that, I'm going to turn it over to my colleague, Maria Crowley.
Thanks so much, Judy, and thank you so much to our first session presenters. That was outstanding information, and we really appreciate it. I am Maria Crowley with ACL's Traumatic Brain Injury Technical Assistance and Resource Center. I am a white female with short silver curly hair. I'm wearing a black shirt and a tan jacket, and I have what appears to be a bookcase behind me. A pleasure to be here with you. And I have the honor of introducing our next session and presenters to you. And as they are getting ready to share themselves, if you guys would come on camera and audio, we are going to spend some time talking about employment and brain injury. I don't think I have to tell you how important work is for all of us beyond a salary, how important it is in terms of giving us a sense of purpose and identity. It's good for our physical and mental health. It strengthens our social bonds and promotes inclusion across all spaces. It decreases public spending, and it's good for our economy. And with you are going to be some very dear colleagues and friends that are going to talk about why that's so important and some resources to assist with employment, particular to traumatic brain injury. Welcome. With you today are these three wonderful ladies, Amy Gonzalez, who's the project manager for the Disability Employment TA Center, which we call the DTAC, Eileen Kelly, who manages the TBI grant with Minnesota's Department of Human Services, and Jill Farrington, who's a technical assistance advisor with the National Association of State Head Injury Administrators. Welcome to all three of you.
Thank you.
Thank you, Maria, for that introduction. I am Amy Gonzalez, a Latinx woman. Now that my birthday's coming up, I will say middle-aged. I am joining you from my home office with a bookshelf and a fish tank in the background, and it is great to be here today. We are very excited to be here. Next slide, please. So what I'm going to do very briefly is I'm going to provide an overview of the Disability Employment Technical Assistance Center, the DTAC. We're going to talk a little bit about some of the employment resources that we've created at the DTAC. We're going to talk about the structure of the technical assistance that we provide to grantees. We're going to take a dive into a new exciting technical assistance opportunity that we are looking forward to sharing with everyone. And then we'll wrap it up and turn it over to the next presenter. So let's get started. Next slide, please. The Disability Employment Technical Assistance Center is a 5-year contract funded by the Administration on Disabilities. We are charged with 3 primary goals. One is to increase competitive integrated employment outcomes for people with disabilities that are touched by the grantee network. So, for example, say there is a Center for Independent Living serving individuals with disabilities that are focused on getting some volunteer opportunities or connecting to employment. Another example would be a traumatic brain injury grantee working with a person that has brain injury, supporting them on their journey to employment. That looks different for everyone, but as long as we focus on providing the TA to grantees and focus on those outcomes, is what we're really aimed at doing. We also work to increase economic self-sufficiency for the folks with disabilities that are touched by that grantee network. And then another one of our goals is to enhance grantee partnerships. So whether that's maybe looking at exploring a new partnership, what that would look like, components of that, the next steps, or maybe just enhancing a current partnership with another grantee, or perhaps vocational rehabilitation to help us enhance those outcomes for the people that we serve. We have 3 themes that our technical assistance is based upon. That is systems change, innovation, and collaboration, because we want to move the needle on employment, because we want to be creative and innovative in the TA products and the technical assistance that we provide, and because we believe that teamwork makes the dream work, and the spirit of collaboration really does focus on impacting the people that we serve and that we're supporting. And just a quick recap, the grantees that we serve are Centers for Independent Living, State Councils on Developmental Disabilities, State Protection and Advocacy Agencies, university centers, USEDS, Traumatic Brain Injury Program. And then about a year ago, we recently welcomed a new grantee, which is the Projects of National Significance Community Collaborations for Employment. And there are 7 of those grantees. Next slide, please. So I'd like to provide a rationale, a better understanding of how we're started in our journey to provide technical assistance. And how we did that was by facilitating an environmental landscape assessment. We met with AOD staff. We met with grantees that have received services, people with disabilities that have received services from grantees. We met with families, and we also met with grantees themselves. We also took a deep dive into the publicly available data that we received from our funders. And through those discussions and the assessment is how we ended up coming up with the landscape assessment report and the appendices for each grantees. I shared here the link, the specific appendix for traumatic brain injury state partnership programs. And that is pretty much our governing, guiding body to the elements that we provide training and technical assistance with. Okay, so we kind of just didn't say, hey, we got this funding, let's provide TA. We did research, we did interviews, we reviewed data, and then that is what informed our technical assistance plan. Next slide, please. So let's talk about the array of technical assistance that we provide. We provide national community of practice webinars on a monthly basis. It's 1 webinar a month with grantees, with folks with disabilities that are doing innovative work in the field, that are applying promising practices in the work they're doing, and they are seeing results. So we bring in these experts to educate, to inspire, and to show grantees how they're moving the needle on employment and how they can do that too. We also produce a series of podcasts, blogs, and publication briefs, okay? And in just a moment, when I go on to the resource part of the DTAC, we'll talk about blogs and podcasts in more detail, okay? We also have a learning management system. Currently, that learning management system has 5 courses. 1 course that focuses on building an employment program for Centers for Independent Living. Another course that focuses on financial education. So what is the ABLE Act? what are some resources that folks can learn about and tap into if they're worried about losing their benefits when it pertains to employment. We also have a course about assistive technology and employment. It highlights resources for folks with disabilities and their support staff, especially if these individuals are interested in maybe employment or community engagement and living. We have another course focused on state councils on developmental disabilities and employment. And then the fifth course that we uploaded this past year was focused on employer engagement. So taking grantees through a process of examining what those relationships look like with employers, how those relationships can be improved upon, and how to move forward with having a better strategy and targeted communication effort when engaging with employers to place the folks that we work with in employment. And then we have a sixth course that's coming up this year, actually next month in March. And this course is going to be focused on self-employment. So what is self-employment? How do folks and states and grantees and other folks get funding to secure some of these supports and services for people with disabilities who are interested in becoming self-employed and becoming entrepreneurs, okay? In addition to the learning management system, we also have e-learning communities, results in system excellence e-learning communities, or RISE e-learning communities. And these learning communities are time limited, focused on specific topics grantees need to help increase outcomes for people with disabilities. It's high impact, and we definitely welcome and have a structure of kind of that peer-to-peer. So we have folks talking to each other, sharing strategies, sharing tips, sharing lessons learned. And we have found that grantees really appreciate the opportunity to share on a closed, kind of intimate setting, but also through the broader group. Thus far, we've had 6 e-learning communities in 2021 and 2022. In 2021, we facilitated an e-learning community focused on helping state councils on developmental disabilities excel their employment goals in their plans. We also had an e-learning community focused on building back better. And that was working with grantees to vamp up and shift those practices that have kind of closed down or changed in structure due to COVID. And then we also focused on walking the walk, which was a journey to take grantees to how supporting individuals of color in the service delivery system and the services that we provide them. And then in 2022, we also had a cohort on assistive technology and employment. So what are some low-tech and high-tech resources that folks can use to empower and support folks with disabilities to get in the community? We also had one on financial inclusion, and then on employer engagement and partnership. And then this year, we have one on cultural diversity. We have one on engaging SILs and youth in developing best practices and experience to that lead to employment. And then we have another exciting opportunity that I'm really excited to talk about in just a moment. So let me keep going. Next slide, please. And these are just a few resources that I'd like to highlight today. And some of these, most of these, especially those at the top, were developed with our partners at NASHA. So some of these are either podcasts or blogs, but some of the resources that I'd like to highlight today is one particular resource on how you can work after brain injury. So there's some tips and some tricks in that resources. There's also some documents that you can access about becoming a champion for employment and guiding people with brain injuries towards work. So I'm not going to go over this extensive list. There's hyperlinks. You're able to access those links and then come back to us if you have any questions or need support. Next slide, please. So I'd also like to inform you about some other resources that we produce in conjunction with NASHA and some of our other subject matter experts. So one of the really, really cool products that we're getting a lot of traction on are the business side of things, the employment and brain injury podcasts facilitated by NASHA with some other partners. It really gives us a better understanding of the key ingredients that we need in a relationship to move the needle on employment and really support folks with brain injury to excel with their employment goals. We also just released a podcast with our self-advocate advisor, about the new normal and being able to continue working and continue with our lives as best as possible, despite the fact that the COVID is still existent and there are still quite a bit of concerns relative to being in the community and participating. In addition to that resource, we also have some blogs highlighting best practices in supporting folks with brain injury and how to use and take advantage of the power of technological accommodations when we're supporting a person with a disability to get to employment, to take a deep dive into exploring what that's going to look like for them. Next slide, please. All right. So I'm really excited to talk about this. I want us to save some time just to take a deeper dive into this opportunity. So we are very excited to share, in conjunction with NASHA, that we have an upcoming RISE e-learning community that is slated to start in the summer. We're announcing this so folks can start taking consideration of this information, so grantees can start talking with their partners and thinking about if this is a realistic goal for them. But this specific e-learning community is a 4-session e-learning community that focuses on partnership development and identifying opportunities for collaboration within the current grantees in our state and other entities to help people with brain injury obtain and maintain competitive integrated employment. So our partners at NASHA are going to be the lead moderators, the lead facilitators for that session. And they, I believe that there'll be some guest speakers, there'll be grantees from all categories is what we're opening up the application to. And this opportunity is really going to be focused on holding hands with grantees, meeting them where they are, and providing them with the resources that they need to understand strategies and increasing partnerships, strategies to up their game in employment in their state. So please keep your eyes be on the lookout. This announcement will more than likely be out come April, come May. What we do is limit registration to about 20 grantees. So space is limited. We recommend you hustle, you try to coordinate with your teams and submit your application. The way you will find out about this e-learning opportunity is if you subscribe to our listserv, is if you check out our Facebook page. So please check out the website, subscribe so that you can get that email announcement and make that application as soon as possible. Next slide, please. And just here, I'd like to remind everyone that we do provide free training and technical assistance, but you have to make the request. You have to reach out to us and let us know that you need the help. So that last hyperlink on the bottom does direct you to our technical assistance page. And then the last thing I want to say, one thing that I didn't talk about is that the DTAC has a grantee representative group. This representative work group, we had many, over 50 applications across the country from leaders all over the US who applied to participate, to help lead us, to help inform and guide the work that we do at the DTAC. And so you'll be hearing from one of our members who are so excited that she's on the panel. And we really look to our work group members as expert in the field, as our eyes and ears in the field. And so I am just pleased and so honored to turn it over to a fellow grantee, a representative work group member and grantee. So Eileen, I believe you are next. Take it away.
Hi, thank you, Amy. That was a very lovely introduction. My name is Eileen Kelly. I go by she, her, hers. I'm an appearing white woman in my early 40s. I'm wearing a blue flowing shirt with white flowers and a lilac jacket. I have a background of trees at my home office, and I am pleased to be here today. So I saw in the chat there were a lot of questions about, is this DTAC developmentally disabled focused? And I would say, to answer that question, DTAC is employment focused. I am the TBI subject matter expert with the connections that can help you through some of your technical assistance. Next slide, please. It's been really wonderful to be a part of this work group and having our experience in states be utilized at a federal level to be able to focus on integrated employment for people with disabilities. I also am a person with lived experience from having a brain injury and a professional. So those two focuses do get represented in our Technical Assistance Center. We're here for anything you need. If you're talking about building screenings, or if you have a case consultation, you have someone who just had a brain injury. This is the now what? This is the door that you can go through. If you are related to our grantees or our independent living centers that are working with us, and you can come to us. So our collaboration, I'm blown away by our national network of the talented, unique people we have that can come up with innovative ways to help you solve your problems. I'd like to talk about some research that I previously did in employment with Voc Rehab. Here in the state of Minnesota, we did a trial pilot of integrating financial services and work and benefit services into our local vocational rehab office to see how that went, serving people with disabilities. Next slide. So I'm going to bring it to the personal level, right down to person-centered. I had a case where a gentleman in his 40s, and he was the head of his household. He worked at that point 30 years for his brother as a machinist, and he carried their health insurance. He had to put his young children through school, and he suffered a stroke. And so he came in to Voc Rehab looking to get back to work right away. Like, he was one of those go-getter work is vital people. However, understanding your own brain injury, and I'll use the word we, because I am a person with lived experience, but understanding our brain injury can be difficult when it first happens. We have to go through tests, if you will, on where our abilities are. And doing that with a vocational rehabilitational counselor is great. But we also have to remember what's most important to the person. And for this gentleman, what was most important for him was that he had health insurance. And so that's why he wanted to go back to work. Work means different things for each of us. So he was frustrated, he was scared, his wife came with him, she was scared in the office, and they wanted benefits. So he thought the only way to get benefits because of their situation and their income and their assets was to go back to work right away. The vocational rehabilitational counselor at that point was like, I don't think you can be a machinist anymore. What else can you do? And we started having conversations around his current abilities. And this is what I would call customized employment. Go to the next slide, please. Now, customized employment doesn't need to be it doesn't need to be self-employment. It doesn't need to be anything fancy, right? And so we looked at the everyday challenge of what he was facing. And so he had worked for his brother, and his brother owned a business, already had a business. He didn't have the ability at that time to do his previous job duties. But when asking him with the vocational rehabilitational counselor, what is it that you do every day now? He says, I sweep every day. I'm really, have a lot of anxiety. I have these nerve issues. I have these vision issues. I've got these headaches. So when it's dark, I just sweep the house. And I said, there's some employment. Sweeping, right? Go back to your brother and see if he can make a job, a janitorial job for you to be able to be paid at least $65 a month and that's in Minnesota, and be able to pay your taxes, Social Security tax, pay your, well, I think it's pay your taxes. So his brother, he went back, his wife and him went back to his brother and said, great, yeah, can I sweep for you when I can? And, you know, maybe it'll be 10 hours a week or something. I just need to make $65 an hour. And his brother's like, why do you need to make $65 an hour? And we had explained to him and his wife was his caregiver at that time, that we have something in Minnesota that they have in, I think, almost every other state that has Medicaid. I don't know if it's a 1619B state or if it's, you know, but it's something called medical assistance for employed persons with disabilities. And this medical assistance is different than financial need medical assistance. You can get certified disabled through your state. You don't have to go, I'm sorry, did I say 65 an hour? I meant 65 a month, sorry. Thank you for that in the chat. And so this benefit is a medical benefit. It doesn't have an asset limit. So you can work. The income, there is no income limit, but you pay the premium of what based on a sliding scale fee of what you make, right? And it is a Medicaid product. It pays for, you know, all of the rehab that he needed to get back to where he wanted to be or could be. So then we re-employed him. And in that re-employment, you know, that's where we started with him. We made sure that he was working and he was doing, you know, those things, and he was okay doing those things. We made sure that his applications then started to go towards Social Security and those more long-term benefits that are needed. And then we helped him with, you know, any other benefits that he might need, any peer support, any, you know, getting into all of those real supports. And I was sorry to hear, I think earlier in the chat, I was listening to folks there reading, and they're saying that they had a brain injury and they didn't get connected to those services, right? So it's really important to analyze the person that's coming towards you, the situation. When it comes to employment, get them employed if they can be, you can do self-employment as well and those things. And so getting a person's sense of self back and getting them connected to services is critical. We can have a lot of data, we can have a lot of programming, but if we don't have that connection into that no wrong door, the person's not going to get served and helped. So then we just continue to follow up and follow up. Each state is different, yeah, and we follow up with the person. And he eventually got back to machining, but you know, part-time, and we then supplemented his social security incentives, so he was able to work and be on Social Security disability. Okay, next slide. And now I would love to turn this over to my colleague, Jill Farrington. Really appreciate her being here today. And please let us know if you have any traumatic brain injury technical assistance needs. There is an email on our DTAC website that we can help you with. Thank you.
Thank you so much, Eileen. I want to wish everyone good afternoon or good morning, depending on where you're joining from today. And as Maria mentioned, my name is Jill Farrington, and I'm a technical assistance advisor for the National Association of State Head Injury Administrators. I'm a middle-aged white woman with medium length blonde hair, and I'm wearing glasses today. I have a green shirt on and a tan jacket on, and I have a blurred background. I am very enthusiastic to be here. The majority of my career was in the vocational rehabilitation system. Worked there for 21 years, but the last 7, I've worked more closely focused on quality of life matters for people with brain injury. So I'm a very strong proponent of making sure there's improved access to employment services for people with brain injury. So we'll go on to the next slide, please. You heard this talked about just a minute ago, but I think it's great to frame and begin this talk with this slide. Why work is important, why it matters, is personal to every individual. On this screen are just a few of the considerations that include things like our improved quality of life, our social network, our sense that we belong and that we have an important place in our communities. Our health, as demonstrated by healthcare, less utilization of healthcare services by people who are employed. It is also shown by income that helps us shape our lives in the ways that matter to us. The opportunities to build self-confidence, and the opportunity for employers to tap into the workforce talent that they may otherwise miss. These are just a few of the areas, but I wanted to begin before we go on to the next slide and talk a little bit about some brief recent data from the vocational rehabilitation system about how services are delivered to people with traumatic brain injury. This is some recent data that I just got last week, so I'm going to put it in the chat for some reference. In performance year 2021, and that means October of 2020 through September of 2021, new applicants that had a primary disability, that means it's the first one they listed when they came in, was 1.1% of all applicants. Now that same year, 1.3% of everyone receiving services that had a primary disability of TBI. And then interesting, and finally, 45.5% of all the people closed in that performance year from vocational rehabilitation were closed in successful employment, 45.5%. However, 42% of individuals with TBI had that same kind of successful employment closure. So we do definitely see a gap there. Now, these numbers do not include non-traumatic brain injury, nor do they include people whose TBI was recorded as a secondary disability, which we know there's many of that. The numbers do, though, seem to point to some interesting observations. It appears that there is not necessarily a drop-off when a person applies to services, at least in this performance year, because sometimes it can be easy to get frustrated with any new type of a program and walk away. But this year, it actually was a slightly higher percentage of people that were receiving TBI services over the applicant number. It would seem that generally people who apply and are found eligible in this performance year moved on to actually receive services. It would seem that there is opportunity, however, to get more individuals to the door of programs like vocational rehabilitation. Now, VR, as it's often termed, is not the only mechanism to get employment services. However, it's the largest, and it truly has the most resources to provide to job seekers. Unless, in some unfortunate situations, there are wait lists. But in general, this is a very robust program with many types of services to offer to eligible individuals with brain injury. It also appears that we have the opportunity to see that more people with TBI leave the program successfully, meaning employed, as there is less of a success rate for this group of job seekers, as we talked about a moment ago. So if we go on to the next slide, let's talk about why individuals don't get connected or served by employment programs, such as vocational rehabilitation. There are a variety of reasons, and there are a variety of actual employment barriers for people with lived experience of brain injury. For instance, Someone may not really know where to begin the process. They may not find that the application requirements feel very friendly, or that they just feel confusing, or they just take too long. Individuals may not be certain that they can work after a brain injury, and they may be unaware of the variety of ways that people with TBI receive supports, and even sometimes technologies, like Amy mentioned, that help people go to work successfully. There's definitely strong messages about working while on benefits. So an individual who's on Social Security disability insurance, SSDI, or supplemental security income, SSI, may believe or may have been told over and over again that working while on benefits will lead to an immediate discontinuation of cash assistance that they rely on, and their health insurance will go away. Eileen talked about that very example a few minutes ago. But this is actually almost always a complete myth. And finally, there may be confusion about what jobs might be a fit, particularly for people who had a career before their brain injury, and they're not quite sure what they can do going forward. They may not know, for example, that retraining may be an option through their local employment program, such as vocational rehabilitation. So if you go to the next slide, through this partnership that Amy mentioned, through the National Association of State Head Injury Administrators and the Disability Employment Technical Assistance Center, a whole variety of these free resources have been developed. Now, you heard Amy talk about them already, so I'm not going to necessarily just list them, but I want to describe how they might be used. So in this, on this slide, there's a lot going on. On the left side is just a screenshot of a resource, and it's called You Can Work After Brain Injury, Improving Your Employment Success. So obviously it's been written for people with brain injury. On the lower right side is a link to this document that is on the DTAC website. And there's also this QR code. If you're unfamiliar with QR codes, or if they're new to you, they're these small black and white squares that hold a specific URL or website link. So if I hold up my phone, I can hover it over the square with my camera, and then I can go directly to this resource. So we're just trying to come up with as many ways to get these resources into the hands of as many people as possible. So if I am given this resource, I'm going to find in this bulletin or this resource guide where I can locate my offices for vocational rehabilitation. It will give me a place to start. It will give me information to find out about where I can get that benefits planning that has been mentioned by Eileen most recently. For instance, if I have heard about this Medicaid buy-in program, I'm really excited to know about it. I need to find somebody who specializes in this topic that can give me sound, accurate advice. And that's something else that this resource holds. It also has information about accommodations so that I can get excited about thinking of the ways that other people have found their way back to employment with innovative accommodations, technical assistance, or assistive technology. And we would encourage that, if possible, these types of resources can be placed on maybe a community agency's website in an area for employment. Or maybe they're included in some online communication, such as newsletters. Or they can be printed out and handed to an individual who is thinking about employment. So let's go on to the next slide. And we'll talk about another kind of set of barriers. And these are barriers that may come up with community providers when it comes to holding up employment for people with brain injuries. If I am a community provider, not a vocational rehabilitation counselor, but maybe I'm a resource facilitator or a resource navigator or a community-based case manager, I may be uncertain how to have a work conversation with a person that has a brain injury. I might be unfamiliar with the employment resources, or I might hear that it's really a maze or kind of tricky to get started. And I may not really know that much about the various accommodation strategies that could help the person that I support work. I may be unclear about what kind of job matching options exist, and I may not for sure know about the available evidence to dispel those myths that we talked about a minute ago that discourage beneficiaries from working. I may not know, for example, about my local community work incentive coordinator or benefits planner. So if we go on to the next slide, this is our next set of resources and some guidance on how to use it. If I was a resource facilitator or a navigator, like I mentioned, I would use this resource, and it's titled Become a Champion for Employment, Guiding People with Brain Injuries Towards Work. Now, I noticed that Cheryl Van Epps in the chat said, it's frustrating that sometimes we have to just find these organizations that can help us and that we don't kind of get nudged towards them more by default or more naturally. This is a way that community-based organizations can become very familiar with this topic of work. It has, again, on the left side, a screenshot of the document. It's multi-page. This is just the screenshot of the top page. Again, the URL and the QR code in the middle. But you can tell from the quote in the center, this is just a small little example of some of the ways that a community-based provider can start up that conversation about work. With language. People in the same situation as you have found that accommodations on the job help them manage their brain injury difficulties or challenges. Let me show you a great online resource to learn more at the Job Accommodation Network. Just an example of ways that I don't have to be an employment specialist. I just need to know enough to encourage individuals to really seriously consider or think about their value in the workplace. Now, some states actually require that employment conversations happen right at the very start of a program, like an intake. Oftentimes, these are states that say employment really matters and needs to be one of the first conversations that we have to let people know that they can work and resources exist to help them. On to the next slide. We get to our third set of kind of potential barriers for employment to talk about today. And this comes up with employment service providers. It may be a vocational rehabilitation counselor or a job developer or a job coach. There certainly can be barriers that come up here as well. An employment service provider, for example, might feel that everyone with a brain injury must have a full neuropsychological evaluation in order to identify brain injury. When in fact, sometimes there are other methods to establish that a person has a brain injury. An employment service provider might be unsure about the array of accommodations and assistive technology options available, especially those that are specific to brain injury or that are newly emerging and really exciting. The employment service provider might not even know that the person they're working with has a brain injury. We heard Dr. Corrigan illustrate this earlier in today's session about the likelihood that service providers are working with individuals that have experienced a brain injury and it's just unrecognized. The person themselves may not know it. And then finally, they may be uncertain how to address brain injury symptoms that are interfering with program participation or job search. One of the interesting things here is that some of the reasons people are closed from programs such as vocational rehabilitation line up exactly with some of the brain injury symptoms that people experience. For instance, failing to show up to an appointment, or just seeming to lack motivation, when in fact, there may be brain injury symptoms that just need to be addressed and adapted to. So on the next slide, we get to the third resource that we're highlighting today, and that is considerations for working with individuals with brain injury. This again is specifically the guide for employment service providers. So if I'm a vocational rehabilitation counselor, or if I'm an employment network provider, or a job developer, I will definitely want to spend time in this resource and look at information such as screening. There's a section in this document about the importance of screening and the ways that that can be done so that I can help uncover brain injury when it exists, and really, very honestly, potentially kind of change the course, help change the course of the life for a person who's been struggling for many years and doesn't know that brain injury is part of the issue. This document will give strategies for the VR counselor or other employment service provider to do themselves to help set people up for success considering brain injury symptoms. It will have links to information about innovative employment approaches. Eileen mentioned one of those a minute ago. Customized employment is an up and coming way to look at every person in a much more tailored, individualized way. There's also rapid engagement approaches and self-employment. Sometimes people that can't work a normal day can take their skills and their abilities and work on an alternative kind of schedule through self-employment. So the final thing to highlight in this document are those different strategies that can help a VR counselor assess for brain injury. It is not one size fits all. So going on to the next slide, we'll just start to wrap with a few other resources that have been developed for this partnership. You already heard them mentioned by Amy. I'm just going into a little bit more detail. So the blog on the left side with the QR code is Job Retention After Brain Injury, Why It Makes Sense. And this is a really great blog to help service providers and individuals with brain injury think about that sometimes there is a way to return to a previous employer. Eileen gave a really great example of it. Even though the person was working just minimally in order to access the Medicaid buy-in. But this blog will highlight rapid engagement methods that might help a person return to work, perhaps through accommodations or assistive technology, maybe in a brand new position. You know, we know that sometimes employers are very interested in trying to make a difference for a person who's sustained a brain injury, and they may be very ripe for conversations about job retention if the individual is ready. The blog on the right, which is assessing brain injury needs while keeping the job seeker engaged, is, as mentioned a few minutes ago, about the topic of assessment for brain injury. The main message is that it isn't one size fits all. There absolutely are times where a person needs a full neuropsychological evaluation. And then there are times where other alternatives may suffice, if nothing else, for eligibility, so that the VR counselor can send that positive message. You came to the right place. You're eligible. We're going to start talking about how we can help you. That's extremely powerful. And making that time frame of eligibility as streamlined as possible helps more individuals not fall out of the process. So this blog goes into some of the specific ways that more tailored assessments can take place beyond the traditional full comprehensive neuropsychological evaluation. On the next slide, we see the podcast that was mentioned earlier as well. And this one is the business side of things, employment and brain injury. There's a link to this podcast. Really well done. Great people, great guests that were moderated by my colleague Maria Crowley. And you can listen to it and you can take away some of the important information that comes from not only the employer perspective, but also from the VR counselor or other staff perspectives as well. You know, one of the really highly impactful pairings that can happen to kind of pair up with for an employer's needs is to see that a brain injury informed vocational rehabilitation counselor can work side by side with a brain injury specialized resource facilitator or navigator. And between the two of them, they can provide really great comprehensive technical assistance to employers, pave the way for that job placement to happen. On the next slide is one more link, and that is to a webinar that was done last year. And it is highlighting an innovative approach between the North Carolina Division of Vocational Rehabilitation Services and one of their community partners called Community Partnerships, Inc. They came up with a way to fund a program that people can come into and get very tailored services leading to employment. And I really highly recommend taking a look at this webinar. We've got just about 1 minute left. And so on the next slide, I'm just going to mention that very much as a review that we do have the 4th resource guide on employment and brain injury resource coming out. And that target audience are going to be centers for independent living. Look for that in March. And then, as mentioned earlier, we do have learning collaborative. What's exciting about this one is that it will definitely highlight examples of how brain injury programs have come together with other grantees, such as Center for Independent Living, to focus in on brain injury and enhancing employment for individuals that are job seeking. So with that, I'll conclude my section and Maria.
Jill, thank you so much. And Amy and Eileen, thank you so much as well. That is a ton of information and a wealth of resources that all of you have at your fingertips that you can access. I think we don't really have any time for questions. I see that there was a fair amount of back and forth in the chat about employment assistance for service members. And I don't know if you guys want to add anything to that, but I would say any of the services and resources that were shared today are also available for people who are service members as well. They are not limited to civilians. Anything you want to add to that?
I would only add that I do think a myth exists that you need to work with the vocational rehabilitation and employment program under the Veterans Administration or your state VR program, when in fact, there's a lot of states that have great collaborations. And then a person with a brain injury who's a veteran can take what they need from both of the programs based on what's offered. A great example is self-employment. So I would just send that off as a message that sometimes an individual can work with both and get even that much more in the way of comprehensive services and supports.
Thank you. Thank you so much. Last thing I'll say is tomorrow is Assistive Technology Day, which is certainly related to employment. And there are a number of assistive technology, low-tech and high-tech resources that are applicable to individuals with brain injury that people can access across all the states. And with that, I think we are at time and we have a 10-minute break in front of you. I know that we are a minute past, so if you guys would come back on at 2:11, we will see you then. Thank you.
Well, welcome back, everybody. I'll be introducing our next session, which will be on peer support. I'm Elizabeth Leaf from ACL, and since I didn't describe myself earlier, I'm a middle-aged white woman with collar-length salt and pepper hair, and I have a tan sweater on and an ACL screenshot office background. Up next, we have 3 presenters, all of whom are members of the TBI Advisory and Leadership Group, which we call the TAL Group, which is part of the Traumatic Brain Injury Technical Assistance and Resource Center, TARC. The TAL group is composed of national experts of people with lived experience of TBI. The major purpose of the group is to ensure that the perspective of survivors is included within TBI TARC activities. The TAL group is involved with and helps guide all of the TBI TARC activities. We like to practice the philosophy of nothing about us without us. Our presenters for this session are Cliff Harmowitz from the state of New York, Carol Starr from Maine, and Maria Martinez from Colorado. Their bios are available on the PDF that you received with the agenda, so please check them out. They have a long history that is worthy of taking a peek at. So at this time, if Cliff is ready, I will hand it off to him to start this next session. Cliff?
Thank you, Elizabeth. My name's Cliff Heimowitz. What little hair I've left is gray. I'm wearing an Argyle sweatshirt. I'm in my home office and I'm wearing glasses. As she mentioned, my name is Clifford Heimowitz and I'm a TBI survivor. I'm also a member of the New York State Traumatic Brain Injury Services Coordinating Council, as well as a New York State Certified Mental Health Peer Specialist. Before becoming a mental health peer specialist, I worked for my local municipality for 15 years as a mobility and disability specialist. I acquired my brain injury over 20 years ago as a result of not being accurately diagnosed in the emergency room after a car accident. In a matter of hours, my life changed forever. I was extremely fortunate that I was seen by a neurologist on call. If it were not for the recommendation of the neurologist to see a physiatrist, my brain injury would have gone undiagnosed. What felt like forever, I remained at home in bed and started to distance myself from my family. No one in my family knew that I had a TBI, nor had any idea where to go to get treatment for it. Fortunately, my neurologist referred me to the physiatrist, who referred me to the community reentry program that was offered at a local hospital. In hindsight, in addition to the therapies I received, having the opportunity to participate in a program with other people with similar challenges was my first introduction to peer support. Once completing the program, my children's mother and I saw an activity for me to participate in to continue to build on skills that I acquired in the community reentry program. The service provider that served the TBI community at the time determined that I was not eligible for the day program because of my high functioning, and therefore they had no support that they could offer me. At that time, there was only one provider of all of Long Island, there was not even talking about TBI back then. Fortunately, as an advocate for public transportation, I met the director of a local mental health organization. He asked me what type of rehabilitation I was receiving. Not receiving any at the time, he offered to provide me with support through his organization in the form of a job coach. He helped me to work on the skills to be able to attain successful employment. Next slide. Challenges faced by people with traumatic brain injury. Now I would like to talk about some of the challenges faced by people with TBI. Following a traumatic brain injury, people encounter physical, cognitive, and psychological challenges that can impact their everyday life and be barriers to living independently. Some of those deficits that are a result of the trauma of the head injury are vestibular, vision, mobility, spatial place orientation, planning, timing and calendar, navigation, and communication issues. If you suffer from a head injury, you're at high risk of developing psychological changes and mental disorders such as anxiety, depression, bipolar disorder, post-traumatic stress disorder. Other common and behavioral emotional problems that come with TBI are verbal and physical outbursts, poor judgment and disinhibition, impulsive behavior, negativity, intolerance, apathy, egocentricity, rigidity and flexibility, risky behavior, lack of empathy, and lack of motivation or initiative. Welcome to my life. People with TBI may have a hard time coping with their injury. They may need to adjust to a loss of independence. They may experience changes to their role in their family and in society. They may also experience changes in personal and professional relationships after a TBI. All these changes can lead to frustration and dissatisfaction with their life. Stress and stressful situations can trigger emotional distress. People with TBI can take steps to reduce stress. For example, they can use relaxation techniques such as deep breathing or muscle relaxation, scheduled breaks, and practice mindfulness activities. Next slide, please. My apologies. Okay. Okay, next slide. Now I'd like to talk about what a peer specialist mentor is. A peer is a person who is currently living with a TBI. A peer can offer support and advice to others who are new to TBI and dealing with similar problems. A peer specialist can introduce a TBI survivor to strategies to address deficits or challenges, such as technology to supplement cognitive deficits. An example of vision deficits would be blurred or double vision, difficulty with eye movement, focus and tracking. A peer specialist can assist them with eye vision therapy to strengthen their eye muscles, which can help with optimizing visual skills. Unfortunately, I didn't have anybody like that. And so when I was going through eye vision therapy, I dropped out because I didn't have anybody to do the exercise with me. It's just a matter of being prompted. Having the opportunity to talk with a peer specialist and share experiences with someone who has also experienced TBI can help the person cope and move forward. It has been my personal experience that the existing service provisions does not address ongoing needs that TBI survivors have. There's increasing evidence for the benefits of peer mentoring interventions across a diversity of populations. A peer mentor is someone who has a TBI who's happy to talk things through and share their recovery experience with somebody who is new to TBI. A peer mentor spends time with an individual who's had more recent injury. They might share their own experiences and stories of the TBI, provide a safe space for people new to TBI to talk about their fears and concerns, and support them to get into the community. Next slide, please. Now I'll talk about the impact that has been derived from being a peer specialist. It means having the opportunity, having the opportunity to have influence in fellow survivors' lives, develop transferable and marketable skills to enhance your professional experience, increase self-awareness and foster personal growth, cultivate leadership, organizational and self-management skills, improve communication and interpersonal skills, connect to the broader brain injury community, and build your network. Next slide, please. In this slide, I'll summarize some of the benefits which come from Zach Hudson, Program Manager of Peer Mentoring at Brain Injury Alliance of Colorado, Denver, Colorado. Maria, I apologize if you bring this up, but you provided me with him as a resource and he was tremendous. I learned from him that the benefits derived from peers are increased community integration and independence, increased confidence with communication and interpersonal skills, and perceived social support, increased satisfaction with life and self-empowerment, satisfaction in assisting others, increasing self-confidence, decreased isolation, and increased self-advocacy skills. During today's presentation, I provided you with some background information about myself and how I started on the road to peer support. I provided background on the challenges faced by people with TBI. I also provided some information about the role of peer specialists and the contributions and benefits that peer mentoring has provided me the opportunity to help others help themselves. It has also provided me the opportunity for personal growth and understanding my mental health challenges as a result of my TBI. Right now, I'm spending a lot of my time working within the mental health community to try and promote in New York State peer leadership for TBI survivors. Hopefully, with the help of the Office of Mental Health, we can introduce into our peer mentoring curriculum information about TBIs. Even though I'm a TBI survivor, I still am an effective mental health peer advocate because of my experiences in the mental health field. I thank you for this opportunity, and I look forward to someday being able to talk about peer mentoring available for people with traumatic brain injuries in New York State. Thank you very much and have a great day. Appreciate it. I'm done.
Thank you, Cliff. Carol, are you ready?
Yes.
All right.
Hi, everybody. I am Carol Starr. I am a middle-aged white woman with blondish brown hair. I'm wearing a blue sweater, and I am in a room with a wooden cabinet on the right and a plant in the background. I am delighted to be here today to talk about peer mentoring, because this is a topic that is near and dear to my heart. I have been living with brain injury since a car accident all the way back in 1999. And I've been involved with peer support from many different angles. I have been mentored. I am now a mentor. I have run a mentoring program. And I have watched the pandemic basically kill that mentoring program. So what I'm going to do is I'm going to share my experiences with those things and some of the lessons learned from all of that experience around peer support. Next slide, please. This slide is very intentional, both the title as well as the image. I called it the magic of peer support because when two survivors get together and talk, there is magic that happens because there is this relief at being seen, at being heard, at there is someone who gets it. As much as we need professionals who help us, we need each other too. We need our peers, because when you're lost in the throes of brain injury, it feels really alone. And when you meet somebody who's also been through it, who has navigated the terrain of brain injury, hence the map there on the left side of the slide, then you feel like you have met someone who can help you navigate, who can help you figure out, well, how do I go through this unfamiliar territory? How do I climb these hills, to swim these channels? Because that's what brain injury is. It is a whole new world that we have to live in. And our peers can help us do that. And it's my opinion that part of the rehab process needs to be helping us find our peers, because that doesn't necessarily happen all on our own. I never would have met my own peers if rehab professionals hadn't kind of greased the wheels for me to do that. And the reality is that our rehab services, they are always going to end before we're ready, just because of the realities of insurance. But our peers, they can be there for us for a very long time, whether that's through a support group or through this one-on-one peer mentoring, that we're not professionals, that we can't offer that kind of help, but we can offer each other a different kind of support that is so very valuable. So as I mentioned, I am going to talk about my experiences kind of through the life cycle, I guess you could say, of peer support. So I did receive peer mentoring. I didn't make my way to brain injury rehab until it was about a year after my injury. And the program that I was part of, they had a peer counselor there. And it was on my schedule, and I met with her. And what's interesting is it didn't go very well, that I didn't really mesh with her. She was actually older than my parents. She had her injury when she was late in her career. So she had a long career before she had her brain injury, whereas I had mine when I was 32. I had my injury almost before my career even had a chance to get started. Her injury was decades older than mine. There was a lot of dissimilarities between us, and I wasn't ready at the year mark to acknowledge that I am a brain injury survivor. I was still pushing away that notion. But what's interesting to me now is also part of that program, there was a group that was meeting. It was a Strategies for Living with Brain Injury group. And within that group, there was another person who also had a brain injury. Her brain injury was a few years older than mine. She was also an educator. We were a little bit closer in age. And turns out we liked each other. We started going to lunch once a month, and we would talk about our injuries. And even though the mentoring from the quote official mentor, it didn't work out for me, although she would actually become my mentor later on, and I'll get to that in a little bit. Meeting with this person kind of informally that actually worked for me. That I wasn't ready to acknowledge like every, twice a week that I was a brain injury survivor, but kind of once a month at lunch, yes, I could. And she knew more than I did about living with brain injury, but not too much more. And it felt like we discovered some things together. So that helped me through those early times after the injury. Next slide, please. So some of what I learned from being mentored was that timing of peer support matters. That if you hit somebody too early with it, most likely they're just going to recoil from it, and it's not going to work. That the matching process is important, whether that's through chronological age, brain injury age, stage of life when the brain injury occurred. Not everything has to match, but I think there has to be enough similarity for there to be some kind of a mesh that goes on. And I also think that peer support can be informal as well as formal. That the formal did not work for me, but that informal of that new friend and I just getting together for lunch once a month, that worked wonders for me. Now, I don't know at the rehab facility, did they put us in this group together because we were similar? We were both educators, we were similar in age. I have no idea whether that was kind of a planned thing or not. But I think now that, well, that could be. There's no reason why programs can't think about those sorts of things and set the stage for informal peer mentoring to happen. Maybe it will, maybe it won't, but I think there's an opportunity there for those sorts of things to happen. Peers can be valuable in supporting the treatment process. When I was early on in my own injury, I pretty much refused to use strategies. I was going to do things the way I'd always done them. Everything my therapists were trying to tell me about needing to use strategies, nope, nope, nope. It was actually my peer. She was the one who got through to me about that, because she was far enough along in her journey that she had seen that strategies are necessary. And I could see the success that she was having with them. And that softened my stance. It made me say, well, if they're working for her, maybe they could work for me too. And it helped me to be more willing to listen to my therapists and who are trying to teach me some of these strategies. And I'm talking about peer mentoring early on in the brain injury journey, but peer mentoring can happen at many stages. I mentioned that my mentor did not work for me early on, but a number of years later, when I was early on and doing presentations, she was doing a presentation at that same conference. She became my mentor for learning how to do presentations, for how to be a mentor myself. And she was the perfect person for that. That she became a tremendously influential person in my life. I credit her for the fact that I'm here now from everything that I learned from her. So as brain injury survivors, we can have mentors who help us learn how to live with brain injury, but we can also have mentors who help us figure out, well, what are we going to do with this brain injury? If we can't work, how do we find a meaningful way to occupy our time? A lot of what I've learned about being a mentor came from the group that my mentor Bev and I founded. It was called Brain Injury Voices, and it ran from 2010 to 2021. Next slide, please. You can see what this group accomplished over 11 years together. More than 22,000 hours volunteered. We did 2,100 plus hours of sessions of peer mentoring, more than 200 workshops, presentations, and keynotes. We came about because my mentor and I were running a support group in 2009, 2010, and we realized that, hey, there are a lot of people in this group who they're ready to do more. They are ready to use their stories to help others. We put together a flyer, sent it out in the support group, and said, well, what's going to happen? And 9 people showed up. And over the years we grew, we fluctuated between 9 and 12 members over the course of the years. And we were partnered with a local hospital that provided us with a staff liaison and training. And it was through Brain Injury Voices that I learned to be a mentor, that I learned how to run a mentoring program. So I'm going to share some of what I learned from that with the next slide. That when being a mentor, it's important to receive training. That as part of Brain Injury Voices, we received training from the hospital staff where we were mentors. We did a lot of role play about various situations so that we felt comfortable dealing with different situations that people might talk about. We learned about that it was important to recognize what our boundaries were as peer mentors, that we're not medical professionals, that it's important to kind of know our lane, that we share our experiences, but we can't tell somebody what to do. We can say, this is what worked for us. But the person has to make their own decisions, because we are not, as mentors, we're not in the business of telling someone else what to do. That as a mentor, it was important for us to have resources to get help if we encountered a situation where, this is above my pay grade. This is somebody talking about something that I have no idea what to do. And that's where for us, it was really helpful that we had the backing of a hospital. We had staff there that were able to help us. And that gave us a lot of confidence that we weren't alone in this. We weren't just kind of off trying to do good work, but didn't really know what we were doing. And Cliff was mentioning some of the rewards of being a mentor, and we definitely experienced that feeling of we're using our experiences to make a difference for others. That as hard as brain injury is, at least we can make it a little bit easier for other people. So my mentor passed away in 2014. So then I was running the program by myself, with support from the hospital staff. But some of the lessons I learned from running a mentoring program, in the next slide, that it's important to have champions, to have people who really support the program. That we had people at the hospital who are in the outpatient program, in the inpatient program, people that saw the value of peer mentors, because we could say all we wanted to. Here we are, we're peer mentors. Well, where are we going to mentor? So we needed people to believe in it as much as we did. We needed a system for pairing mentees with mentors, and that's where our partnership with the hospital came in. That they had weekly staff meetings where they knew who we were, they knew who their patients were, and their matching would go on that way. We also did a lot with having opportunities for members of Brain Injury Voices to share their struggles at our meetings. There was always time to talk about mentoring, not without names, but with what's going on, any situations that you're having trouble with, what are your successes. And I tracked things. You can see I tracked the numbers, because I can't hold a regular job because of my brain injury, but this felt like a job to me. And it was really very rewarding to see those numbers, to see how many volunteer hours we were putting in and how many presentations and the number of peer mentoring sessions. So, and I shared those numbers every year with not only the hospital, but the State Brain Injury Association, with anybody that we had come into contact with, knew about what we were doing. One of the sad parts of the pandemic was the gradual ending of Brain Injury Voices. That because of the pandemic, we could no longer meet at the hospital. The staff person who had been our liaison was let go, was laid off. And so we lost all of our supports. And it's just me and 7 or 9 people on Zoom. What do we do? And then it got hard. So I'm going to share a little bit of what I learned from the ending of the program. Next slide, please. That it is difficult to maintain a program when those people who we relied on as your champions, when they leave or they retire, because in reality, some of this was happening even before the pandemic. We had our person in outpatient had retired, in inpatient, sorry, had retired. We tried to find a new person and we couldn't. And our numbers in that section of the hospital had declined because we couldn't find a person who believed in the peer mentoring like the previous person did. Organizational challenges can impact the process. The hospital changed their meetings. They weren't doing staff meetings anymore. And those staff meetings were the ways that we were matching mentors and mentees. Now suddenly we didn't have a way to match. And then with the pandemic and the loss of the meeting space and our primary staff person being laid off, then it was just me as a leader. And I couldn't do it alone because as a survivor, I need support too. And we as a group decided that it was time to sunset what we had done, knowing that we were taking everything that we had learned into next steps, that even though Voices isn't active anymore, people are still using those skills that they learned. There's one person who's working with children, another person who's working with a disability organization, another person who's doing peer mentoring on mostly on social media. And we're all still connected to peer mentoring in a variety of ways. I'm doing presentations like this, and I'm waiting. I run the support group. I'm waiting for the next me. I'm waiting for other people who want to peer mentor so that I can be a mentor to other people and to complete the cycle, because I wouldn't be where I am today without my mentor, without her showing me what is possible for brain injury survivors to do. And now that I'm, long in my own journey, that it's my opportunity to do that for other people and to help other people to find their way. And that's the beauty of peer mentoring, is helping other people on their journey, whether that's the journey at the beginning of brain injury or the journey to make meaning of it and to help others. And so I'm happy to talk with folks about mentoring from an individual standpoint, from a support group standpoint, from creating an organization like Brain Injury Voices standpoint. So I'm now going to turn it over to Maria to talk about some of the mentoring that she has done.
Good afternoon. My name's Maria Martinez. I am an older Native American woman with long hair. My background image is a calm green color and an image of a plant. I live in Pueblo, Colorado, and throughout my life, I have experienced concussions related to high impact sports. My world became more complicated in 2007. After a motorcycle accident, in 2009, a vehicle pedestrian accident, and a stroke in 2010. I'm a director of the Pueblo Brain Injury, a nonprofit, Re-Inspired Minds, and I provide support groups, classes, in person, on Zoom, hybrid, and I do outreach in the Pueblo County. My presentation is based on peer support with creativity. When I think of rural, I think of traditional cultural expression. I think of elders who are the storytellers, people of different cultures and languages. I think of music, landscapes, signs and symbols that are faded and no longer there. I think of livestock and community, dirt roads, 2-lane highways, wildlife, agriculture. It's just country. And when I think back in the day, peer support was creative. It was those individuals with lived experience that mentored the community when you needed its support. They were there. Next slide, please. Rural populations are lanes of lonely rural highways. Today, rural population requires miles of travel to obtain resources. Participating in face-to-face peer support does not occur. It doesn't occur at all sometimes. The changing landscape is the events that changes the peer's life. It's the vehicle accidents, the anxiety, the domestic violence, the suicide attempts, PTSD, aneurysms, parent abuse, substance use, caregiving, assaults, depression, multiple disabilities, homelessness. The consequences seem endless. When I think about how individuals who are impacted by traumatic brain injuries, acquired brain injuries, or experience both, I think of the peer support in rural communities that continue to be a challenge. The challenges that providers, community agencies are not aware of resources available, mainly addressing brain injury. For example, brain injury waivers, support groups, mentorship programs. There are those peers who are not aware of peer support. Some are, and others may not be interested or not ready. Peers have expressed their appreciation when they experience peer support, not only from those with lived experience in brain injury, but those that are grateful for the lived experience from peer support in areas of mental health and substance use. The need for peer support from those who have lived experience, have overcome personal challenges, and continue to practice their own peer support needs is very valuable. It brings that experience of gratitude and resilience from peers who can access support. And my hope is those are the generations of mentors. Next slide, please. The contrast of images that you see on the screen is when peer support is available and when services in rural population is expressed by being left out. Next slide, please. Or I'm sorry, stay where you're at. Paid certified peer support specialists, counselors. It's a profession that requires training. For certification, individuals can be authorized to go through the Division of Vocational Rehab for assistance. The cost and the hours of training can vary from 80 hours or more. There's recertification requirements. Programs can be supported by SAMHSA, the Substance Abuse and Mental Health Services. There are exams that the Colorado Providers Association can provide. That's the availability of receiving paid certified peer support. The trained volunteers are people that follow the guidelines, such as the Brain Injury Alliance of Colorado provides a peer mentorship program. Their guidelines are in the best interest of the mentee and the mentor. The program connects survivors throughout Colorado. The duration is approximately a year with weekly contacts via phone, video, and if possible, a monthly community activity depending on availability. My experience is that the training and the forms and the background checks, the policies, made me think of my commitment, my responsibility in supporting a peer. As a member of the Colorado Behavioral Health Advisory Council, I have seen the commitment from people with lived experience from rural and frontier to include those with brain injuries and other disabilities. They advocate for peer support in mental health and substance use. They work with passion towards changing the path for individuals in receiving more accessible care to include peer support in Colorado. Benefits of informal peer support. Using informal peer support, I found, allows for community, and that community mentors each other. It allows for supportive relationships to develop on their own, their support groups, their activities, their classes. The training, such as the Self-Advocacy for Independent Life program and the mentorship program in Colorado, allows a way for peers to enhance their lives by incorporating them to support each other. It builds a resource of knowledge that is shared with those they connect with, whether it's virtual, in person, whatever the technology that they use. It's a sense of belonging that other peers can relate to. And that's the importance of, if we don't receive enough peer mentoring for those that live in the rural population, that's where the informal peer support is an asset to us. Next slides, please. This slide is, I say Chile's not one is alike, and that's the same way I see about brain injury and acquired brain injury. I also feel that the culture is a palette of life, that the diversity of mentoring, it's like providing mentorship is like Chile's. It's like what's in the photo. It's not one is alike. There is a need to develop a trust that you don't have to navigate your experiences alone. Finding the connections with the community opens the feeling of being accepted. It allows yourself the ability to be creative in supporting peers. I believe that can be accomplished through formal and informal mentoring. Mentoring can provide resources to assist in self-care, self-advocacy of one's own mental health by using the resources like state behavioral health systems. It allows individuals to fine-tune how to care for the whole person, not to separate themselves, but to care for themselves as a whole person. Mentors need to be informed of community resources. They need to stay attuned to it, as well as state resources. It empowers our knowledge and our ability to provide peer support. Next slide, please. I want to thank the peers who shared their stories and experiences with me and that allowed me to share it. I have a lot of passion for the advocacy of people with brain injuries. It's so imperative that we continue to mentor and we find those people that are eager to share their experience as well. So thank you for allowing me to speak.
Well, thank you all. This has been a very impactful presentation. I know for me, peer support is just a rock solid part of my life and my daily life. And I think every single one of us on this call have been peer supporters at one point. But thank you to Cliff and Carol and Maria. Your stories were very impactful, and we appreciate you sharing. At this time, I'm going to ask Judy, did we get any questions for our presenters?
We do have a couple of questions. And this was directed to Carol, but I'm thinking anybody can answer the question. Actually, a couple of these were. So what are your thoughts on level or need of commitment from the mentors? Should there be a minimum time request? That's the first question.
Okay, so let's think about that. Well, I can tell you what we did with my Brain Injury Voices group, that we had our monthly meetings, that we were a volunteer group, so attendance was hopeful. and most people did attend most of the time. That I think, especially to start out, you need people to attend probably more. What we did was we kind of did a retreat. Actually, I was at my mentor's house to start. We did a lot together at the very beginning, which got everybody on the same page. And then people were able to mentor more independently. Because at first, we did mentoring in pairs at first, because people were felt a little bit uneasy. We didn't put like a time frame on it, because some people could do more, some people could do less. And some of it was sometimes people were mentoring for an hour at a time. Sometimes it was 15 minutes. It depended on the situation, because some of it was more formal, like in the hospital. Some of it was, a lot of us participated in a recreation program. Some of it was while we were snowshoeing, we were mentoring, because we were with another survivor out on the trail and talking about, living with brain injury. And we called that mentoring too. So it wasn't that structured in terms of you must do this, but I did want people to attend like the monthly meeting. So we had that opportunity to talk about whatever it was that whatever mentoring situations were coming up.
That's great. And actually, just stay put, Carol, because there's a few questions for you. What are your thoughts on how peer mentoring programs can be improved? What innovative strategies can be implemented to better assist the community? And again, if others, Cliff or Maria, have things to offer on this one, I think it could be opened up. So sorry, Carol, if you have things to say.
I think too often peer mentoring gets pushed to the side. There's no time. There's no time to have somebody, get somebody to the support group. Well, we'll tell them about it. Or the support group is, we'll make it at night, because then it won't interfere with rehab therapies. I don't know about most, I can't drive at night. I can't go to a support group at night because I can't drive at night because of the light sensitivity. Sometimes I think it gets viewed as the ugly stepchild. And I think it is so much more valuable than that. That I think that making peer support part of somebody's rehab and ensuring that somebody finds that level, I think that is just as valuable a rehab goal as other goals that are set. Because like I said, our time in rehab is going to end. But our time in a support group, I have people attending the support group that I lead. They've been attending for decades. The support group that actually was one of my therapists, she helped me get there. I never would have gotten there on my own. I would have said, yeah, I don't know. But she said, no. This is during our session. Come with me. So I knew somebody there. She introduced me to people, helped me find somewhere to sit, because it is a tremendously brave thing to attend a support group for the first time. And it's hard to do. And when you know somebody, when you get somebody can say, here, sit here, when you know somebody maybe ahead of time, those things can make that easier, that warm handoff. And that stuff doesn't happen by accident. That stuff only happens with planning.
Great. And then Maria, someone asked about the peer certificate website. Did you mention a peer certificate website? And if so, do you have a link or something that we could put in the chat?
Yeah, I'm not a multitasker, so I could put it in a bit.
Okay.
But I think it's, one of the things I want to say about mentoring is that I really feel that people have to be creative at whatever geographical area that you're from, whatever demographics that you address. I really feel that when you don't get those accesses, I think that's where the ability to be creative and push forward as far as outreaching and reaching as many people as you can, providing the education. So, I think that's a real need.
Great, thank you. And then Carol, you had mentioned about your program Voices, which a person put in the comment, they're sorry to hear it's not running, but respecting how hard it is to keep these programs going. But they were wondering where they can find out more information about it, specifically thinking about what training you offered. And again, I would say for anybody who has offers on training, please share.
The website is still active. It is braininjuryvoices.org. I can put that in the chat. And the training that we received was created by one of the staff people at the hospital. Just so there's no information on the site about the training that we received. There on the site are our bios, our videos of some of the presentations that we did. Those sorts of things are there.
Great. And I see we put the name or your
okay. All right. Already there. Excellent. I don't even need to put it into the chat because I'm like Maria, I'm also not very good at multitasking.
It is a challenge.
Yes.
So Elizabeth, that was the end of the questions that I saw in the chat.
Thank you very much, Maria. I think at this point, we're going to the intersectionality part of our presentation. So I will hand it back over to you, Judy, to introduce our guests and carry on. Thank you.
Great. Thank you. I also just want to point out, if you're not looking, Carol, Cliff, and Maria, take a look at the chat. There's some really excellent comments in there, and thank you for your session. Okay, so I have the honor of introducing our last session of the day, and we're going to talk about the intersectionality of brain injury and other medical and social issues. So with us for that, we have Sean Calloway. He's the Project Officer for the Administration for Community Living, Office of Disability Services Innovation. He's going to speak about the intersectionality of blindness and brain injury. We have Eric Washington, who's one of our TALL group members, as we mentioned TALL last session. He's going to talk about the intersectionality of TBI mental health and homelessness. And then Martin Corrigan, who is also a TALL member, will talk about the intersectionality of TBI and substance use. So with that, I believe I'm turning it over to Sean.
Well, can you hear me? Good afternoon. Can y'all hear me?
Oh yeah, now I can. You were breaking up a bit. Talk a little bit more and we'll see.
Okay, can you hear me?
Yes, very good. Thanks, Sean.
Okay, thank you. Well, first of all, thank you for having me on this outstanding program. I come to you from the perspective of blindness. I was not always blind. I was totally sighted for 19 years, first 19 years of my life. I went off to college, and during the second year of my college experience, while in my dorm room, a young man came into the room playing with a gun, and the gun went off, and the bullet struck me in the temple, which caused me to be blind instantly. Of course, I was rushed to the hospital and spent several days in the hospital. During that time of coming home, and I put myself in what we call we call social isolation. I started experiencing seizures after the accident, and I had to go to the hospital and realize that I had some complications from the accident, which caused to have some sort of brain leakage and things of that nature. So that had to be patched up for myself to get back together. After a few years of really just sitting around trying to figure out what I wanted to do in my life, I finally decided to seek what they call independent living training, which is to learn how to read Braille, learn what we call orientation mobility, the use of the white cane, learn cooking and different type of skills. And once I went off to acquire those skills, and once I did acquire those skills through comprehensive training, I decided to go back to college. Now, after, like I said, after having this training, I went back to college and I was able to acquire an associate's degree in psychology. a bachelor's degree in, a bachelor's degree in psychology and a master's degree in social work. And I've held several jobs, ranging from a social worker at a substance abuse facility to a social worker in public schools, and then, of course, coming here into the federal government. Now, I know you ask yourself, I just told you a whole, the little short story of my life, and TBI was not mentioned one time. Well, the reason why I was never mentioned was because I did not realize until 2021 that I had a TBI. I was working under the Office of Intellectual and Developmental Disabilities, and they told me that they wanted to switch me over to the ODSI, which the TBI program is housed under. And so, of course, when you are transferred into a new program, you want to learn about what you're getting into. So when I started reading about traumatic brain injuries, it was almost like I stepped into the twilight zone. I realized that a lot of the symptoms that the individual have when it comes to TBI, I had them coming up. Now, I mentioned how when I first came home after my accident, no one ever told me that I could recall that I had a TBI. Matter of fact, once I realized I had a TBI, I called my dad. I said, Dad, did you know that I had a TBI? He said, no, this was never related to him. And so I went through, starting at the beginning point of coming home after my accident, suffering from some severe major depression. I mean, I had, everything from insomnia, social isolation, I heard the term low motivation. I had it all. But again, not knowing that that could have been associated with TBI, it just was never diagnosed. It was never mentioned because, of course, the blindness was what took over. Now, when we talk about moving on into my training and independent living training, now, my orientation mobility training was very tricky because I noticed I could not walk in a straight line. Every time I walk, and this is to this day, I always veer to the right. I cannot walk straight. And I never could understand that. I thought it just had to do something with my vision loss and not having some unequal, I don't know the term, equilibrium, but I just didn't understand why this was going on. But then when I read up, of course, on TBI, I realized that's what was the issue. And then, of course, when I got to college, my attention span was extremely low. I could hear listen to a professor for a few minutes, and then I'm drifting off. And then I have to come back and then sort of to reality in a sense. And then all of a sudden, I'm behind, not understanding what was actually happening in class. But what covered that up for me again, and not knowing that I had a TBI, I was able to record my classes because of my blindness. So then if I didn't understand what was going on in class, right, I was able to listen to the recordings that I had that I taped during class and kind of get an understanding of what I missed during that class time, even though my attention span was extremely low. And so this kind of occurred, especially as I went on through into the workforce. I would often just wonder, why is my attention span so low? Why am I having some trouble remembering things when I mean, literally, I just thought of something and all of a sudden I just couldn't remember it anymore. And then again, as I transitioned on to the federal government, and then also, transitioning to the TBI program, it was like unbelievable to read that throughout my whole entire life as a blind person, which has been nearly 32 years, I had a traumatic brain injury. I could quite honestly say that, even now, when we talk about the socialization and sort of the stigma towards individuals with TBI, I can give you a perfect example. I told some friends recently that I have a traumatic brain injury, and they did not believe me, and they didn't want to believe me because I was able to get through college, right? I was able to acquire employment. But one person finally said, you know, Sean, I kind of did notice sometimes I would tell you something, and all of a sudden you would ask me again what I just said. And so it kind of clicked with one individual, but because I was, and I know the term was used, high functioning in the previous presentations, but because I was high functioning, it's very hard for it's hard for people to it's hard for people to believe that I have a traumatic brain injury. So, you know, going through this whole process of you know, understanding, I'm still learning. I learned a lot today from the individuals who spoke. I mean, it's literally been about just a year and a half in regards to, you know, knowing that I actually had a TBI. I'm very thankful to Maria Crowley, Judy Detmer, Terry Gonzalez, the TARP team in general, because I'm the lead on the TBI programs. And so through their work, not just with, you know, with us in ACL, but outside of what we do and what they do outside of ACL, I'm learning from them about myself, and the work that they do is translating to me on how I can handle myself better as a person with TBI. I find myself now documenting more, you know, because I thought I had a great memory where I can, you know, kind of remember things that people said. And so now I'm more of a document. Well, I was a documenter anyway in regards to being a social worker, but when it comes to my personal life, now I document things so I won't lose track and won't forget certain things that, you know, I should remember. So that was just a short story for myself. It's quite unique, like I said, to go through life all these years, not knowing you have a TBI and now knowing you have one. I'm definitely in the learning process. I'm in the learning phase, and I'm just absorbing everything that has been brought to me, not only through ACL, but the TBI community in general. So again, just thank you for giving me the opportunity to speak to you all, and have a wonderful afternoon.
Thank you so much, Sean. We really appreciate you sharing your story. If I could ask Eric Washington to come up, that would be great. And Eric, you are on mute.
All right, thank you. My name is Eric Washington. I'm from Detroit, Michigan. I'm a part of the TAL group, or she said, I think Judy called it tall group. So I am tall, I'm 6'2". I think I lost an inch or two. I got on the scale this morning. I am sitting in a room on a gray couch, and I have an imaginary bookshelf behind me because one day I want to get a nice bookshelf. Like I said before, I was born and raised in Detroit, Michigan. I come from pretty much humble beginnings. In Detroit, you have a couple of things. You can either play football, basketball, go to jail, or work at Chrysler, Ford, or GM. So, you know, I chose the latter. I went to play football, and since 6 years old, you know, our football coaches always told us pretty much, you kill the head and the body will follow. Now, I know that sounds pretty bad, but when you play football, you know, you ram heads, and the person with the strongest neck or head, you know, they normally win the battle. So for years, I just crashed into people, fell out of trees, we boxed, we played basketball, fell off of garages, trying to learn how to do backflips and things of that nature. So just in the urban community, it was just, that was kind of how things were. You know, that was, a lot of people did it. We played soccer, you know, we played tag, we fought. So the brain injury community probably was my entire neighborhood. You know, we all suffer for something, you know. For years, like Sean said, I assumed books were boring, or I just would rather watch the movie. You know, I remember the very first time I thought something was wrong, a teacher gave us a book report on mice and men to watch, you know, to read the book. And then I just sat there and kept reading the same page 175 times. And my cousin, she said, you know, they got a movie, right? So I just watched the movie. So that was literally my education for all the way until I graduated. It was Spark Notes, Clip Notes, movies, audiobooks, because I just couldn't retain the information like I thought that I was supposed to. Then we get to college, after playing football, you really want to be a good student. You really want to, do what you were born to do. And I wanted to be a social worker. And I kept going to classes and I just kept flunking out, for some mysterious reason. And eventually it started giving me some help, to kind of help me like focus on my studies a little bit better. So what happened was I might have had 2 or 3 concussions while playing football in college in 1 month, and I would go back in, and the saddest reality is that they gave us a baseline test. And, what happened was a lot of us just kind of didn't take the test serious. So it was almost manipulating the system. So once I had a concussion, it was almost as if my scores were higher because I actually tried to get the answers right rather than the first time. So eventually I get, put back in a couple of times in a game, and then I ended up breaking my neck and getting a concussion. So like Sean said, the secondary injury was the brain injury, and the first was he's kind of paralyzed. So we need to get him back walking, and we'll figure out the rest later. But then we never figured out the rest later. So it was like I came back, and then one day, I just ended up homeless, without a job, nothing. So I kind of was confused. Like, I don't know how I got here. I kept getting fired from my jobs. I flunked out of school, and then I went back to school, and I ended up graduating, but I feel like, I kind of was given some concessions because of what happened. And things just fell apart. Like I said, in many articles or things I talk about, I was a terrible friend, a terrible son, terrible everything. I just wasn't a good person. And it wasn't because I didn't want to be, it was mainly because I just didn't know how to exist. And I was coping with drugs meaning, like, to me, we call drugs like drinking alcohol, but really alcohol mainly. And I was totally unaware that I shouldn't take medicine or drink if it was going to alter my mind, because my mind was already altered. So I would take a sip of beer and lose my mind, or I would end up somewhere 5 cities away and didn't know how I got there. And it was just random things. So I just assumed, like, well, man, I just must have been tired or dehydrated. I kept making excuses until I think the last time I, tried to not be here anymore. And that's when I think a lot of people were like, hey, I think something's wrong. So in jail, the cops always say, hey, I know what happened to you. You need to get some help. But there wasn't any help around where I was located as far as brain injury went. Or, everything was, maybe if he goes to jail, he'll get out and, act right. So that's kind of what that cycle continued to happen. And then once I went back to certain areas and try to get help or tell people something was wrong, it was always, I was bitter because football didn't work out, or I just don't want to work, or I'm just lazy. And I was like, I don't think that's the case, but I think that happens a lot in the urban community. If you saw me walking around, you would say, wow, he's 6 foot, he's a decent sized guy. Why doesn't he have a job? But then, you go to some of my doctor's appointments, or you see me after 8 o'clock at night when my brain just shuts itself down and it's like paranormal activity. You'll be like, oh, I see, I get it now. So for years, I struggled with trying to find the right resources until I came to like this community where I met a lot of people that can help me kind of mentor me back into knowing it's okay to grieve and it's okay to not be the person that I used to be. And that it's acceptable to reach out to people for help, And then now the issues is, what happened is I became homeless. So it made things even more difficult because everything was based off of numbers. And if I can't obtain a job and I won't obtain a job, then I couldn't qualify for certain services. And then I also was dealing with cancer at the same time. So not only do you have to deal with the brain injury, you have to deal with chemotherapy that just rots your brain just as fast as getting into a car wreck. So now I'm dealing with all of these different hurdles and trying to figure it out all by myself. I was found pretty much by mental health. So I went to the mental health, and I really was diligent about it. I finally opened my mouth and started having conversations. And they knew of a brain injury program in Missouri that kind of took me under their wing, you know, at the right time, you know, right when I was ready to give up, when I didn't think that I had anything else to be here for. They were kind of there they couldn't help with the housing piece, but at least they could help try to stabilize me as far as, you know, mentally, or at least getting the resources to try to turn this thing around. So they helped me with I guess he was a person that helped, he was a social worker, but he helped with reintegration into the community. And I credit 99%. Well, I'm gonna give him 80%. And there was some others that they get the bulk of it, because he was just helping me know how to exist. And I wouldn't have been where I am today if it wasn't for him. And the person that actually found me, she was like the motherly figure that I needed at that particular point in time to kind of, you know, grieve and complain. And she would just, you know, it's gonna be okay. So with all of those pieces, that's what made things whole for me. You know, I stopped doing some of the things that actually made me worse. You know, I try to control now I don't let my heartbeat get up too high. I stay out of uncomfortable situations. I stay out of bars. I stay away from games where people are yelling and screaming, because I've noticed that once, you know, my blood pressure raised, then it's like I start getting like off, not delusional, but it's kind of like this random feeling where I feel like I'm not on this planet anymore. So I kind of like just stay to myself and things like that. So once I learned my triggers, then I knew how to exist in this, you know, in this new world of mine, so to say. Like, Sean, you don't know what you don't know. You know, so it was kind of hard to get help when I had no idea what was even wrong with me. And for years, you know, based off the fact of where I'm from, what I've been through, I didn't acknowledge that there was something wrong with me anyway. You know, just the fact of, you know, I'm a brain injury survivor. And I was like, I get it, yes. But at the same time, you know, I'm stronger than this. You know, I'm an athlete. I can figure it out. You know, I figured it was like lifting weights in a different way. But then it never worked out that way. You know, I've been to many doctors, and I had I forget what it's called, some type of therapy where they try to figure out what's wrong, like a neurological assessment. And they just kept saying I was drunk. And I'm like, I haven't had a drink in 5 to 10 years. I'm not drunk. And they just kept saying that because they were like, how could a person that can speak like you do or have an education fail this test? You know, and so I said that was the first time was really emotional, because I normally don't get upset, but I kind of was like so mad I was crying. I know there's people here that's been there before. I was so mad I was crying because I wanted to hurt them, but at the same time I was confused, because I'm like, maybe something is drastically wrong and I'm not getting it. Like, why would I purposely try to fail this just to, what am I getting? There's no prize, there's no money, you know, so I was kind of confused. So that's where I learned that I needed to go seek out actual brain injury specialists, you know, instead of just going to the local the local hospital, because everything was, oh, here we go again. Here's another Black guy that doesn't want to, you know, it was interesting. So I think that just learning how to navigate the system and learning how to help others was it was important in my development and process. So I want to thank you. That's about all I have for now. So thank you all.
Thank you so much, Eric. Really appreciate you sharing your story. If Martin is ready, let's have you go ahead.
Hello, everyone. My name is Martin Corrigan. I am a Caucasian male. I like to think I'm still young, but I'm actually middle-aged now. I am wearing a sports coat, a tie with brains on it, and I'm sitting in my wife's office. You also don't need to, not here to see how I look. So if we can pull up the slides that I shared with you guys. Okay, so this is my story, and it's unique to just me. while the specifics are unique to me, I think this is, the circumstances are unfortunately not all that uncommon. So we're going to go ahead from this point forward. So next slide, please. So on September 25th, 1998, I was crossing the street. I just transferred to the University of Maryland when I was hit by a motor vehicle crossing the road. Next slide. Obviously, I was not dead. The newspaper got it wrong. But for a newspaper to report me as dead, it was a pretty significant injury. Next slide, please. So this is what happened. The early prognosis was there was a diagnosis of a severe traumatic brain injury. I was in a minimally conscious state, better known as a coma, for approximately 8 days. I also sustained some pretty significant orthopedic injuries, fractured humerus, cracked ribs, broken teeth, vision damage, severe lacerations to my hand. The medical personnel were hesitant to make any long-term prognoses, but they did their best to prepare my family for what life could possibly look like following an injury of this magnitude. And I think that's kind of important to note, because for that time period, for them to just say, look, we can't say, is he going to recover? Is he going to, what's going to happen? And I thought that was pretty progressive at the time. Next slide, please. So despite that, I was hospitalized as an inpatient for about 6 weeks. I was able to return to college 4 months following the actual brain injury, and that was 2 months after being discharged as an inpatient. I started off by taking one class at the local community college. Within 6 months of my injury, I was working again, first part-time, then full-time. I got my driver's license back 7 months after my accident. Following fall, 11 months after the injury, I returned to college as a full-time student. So I'm good. I'm great. Next slide, please. And it keeps getting better, right? So to college, I returned to being a Division I athlete. I made a dean's list every semester at the University of Maryland. I'm sorry, at my new college, which is now Towson University. I got accepted into grad school. I started dating again. I graduated. I got a full-time job. I was living independently. So things were looking really, really good. Next slide, please. So the way things look and what was really happening are two totally different things. So what was really going on? I was trying to establish this new identity, right? Like, I was a 19-year-old male when this happened. I was pretty independent, with a pretty decent-sized ego. I think that's not all that uncommon for 19-year-old men. And it's a challenge, right? Because I don't want to admit I'm vulnerable. I don't want to admit I need help. Difficulties with the memory were a huge challenge, but because I had, above average intelligence, according to testing, prior to my injury, I had resources. My family, I had really good insurance. Both my parents were college educated. I had all these things going for me. I was able to figure out workarounds with these challenges, right? So difficulties with memory were a challenge. But what I did is I changed my major, right? And then it was like, okay, education's not really, especially once you get into those education classes, doesn't require a ton of memorization, it's application. I was thinking that I could still do life the way I always had and still get the same results. So for me, my struggles were more from adjusting to life with the brain injury than they were from being a student with a brain injury. I was able to, I was able to figure out how to study better, how to use, simple things that work for me to help me be more successful in school, different techniques or different ways to memorize things, different things like that. But figuring out like, what is this rest of this mess around me that's life, which is hard for anybody, let's be honest. As a, in their late teens, early 20s, but now you throw this brain injury into it, and it was like, what is going on? Next slide, please. So, like I said, it was figuring out who this new me is, right? And it's also coming to terms with the loss of your old life. So, for me, this is a big thing I always like to talk about whenever I get to present to an audience, especially an audience that has any professionals in it or any people that can impact professionals. When we deal with recovering from brain injury, the emphasis is let's get those activities of daily living back. Let's get all these things back. You know, let's what can you do? You know, are you able to work? It's all this focus on, you know, how's your mobility going, right? We don't take into account that, yes, while we're still alive, and that's great and all, part of us died, right? We lost something, and that sucks. And, you know, I know for me, that was never addressed. And I rarely come across individuals that are individuals with lived experience that say that, yes, that was part of their recovery, was this ability to mourn what was lost. And I'm not saying it's to stay stuck in that, but it should be part of the discussion, right? It should be part of an acknowledgement of, yeah, this really is a crappy thing that happened. And like, let's acknowledge that part of this is gone. And then we come to the next part. So partying like we had prior to their injury. So substance abuse, multiple arrests, legal trouble, damaged relationships, etc. So what I didn't mention is at the time of my the brain injury, I was intoxicated. Now, the way I look at it, well, you know, I was intoxicated and I was crossing against the red light. That was only two things I was doing wrong. The guy who hit me was driving on a suspended license, was speeding, and failed to yield pedestrian in a crosswalk and was passing on the right, right? So like automatically it was like, well, yeah, you know, and there was this defense mechanism against me. And you know, we can go to the next slide, please. So what ended up happening for me? So in the 5 years after my brain injury, I was arrested 3 different times. I was hit with another set of charges that were pretty serious. I don't know how I didn't get arrested for it, but I definitely got charged with it. My consequences included legal system. And then as a result of the legal system was also substance abuse rehabilitation. I had to admit that I needed help and reaching out to get that help. And for me, personally speaking, part of that has included a 12-step program. I know this is not for everybody, and I'm not saying this is the only way to get clean or sober, to abstain from alcohol and drugs, but for me, that part of my recovery has included a 12-step program. And then what I've done is my long-term success has been as much a result of the awareness of the impact of the brain injury on my life as has educating others about brain injury and how it impacts me and how it impacts other people. That's like been that to me is been the crux of my success. Now I sit here, and if you know, I'm somebody in the listening to this, or if I'm somebody dealing with an injury, I might be like, this guy, you know, what the hell does he have to be up here talking about? He had this great recovery and everything else. And I'm not going to disagree with that. But as a result of part of that recovery, there was this incredible guilt. And I think that guilt is part of what led me down the road of the drinking to the point where it got. I was told when I was in the hospital following my brain injury that for me to drink alcohol, it'd be like giving a toddler alcohol, that my brain was recovering, that it needed that time and whatever. And sure as I'm sitting here today, I was drinking alcohol before I was even discharged as an inpatient. You know, and you know, there was this, I left the hospital, and in my mind, everything was taken away from me. You know, the girl I was dating at the time broke up with me. I wasn't able to go back to college. I didn't know what my life was going to hold. Now, I eventually got a lot of those things back, but I didn't know that was going to happen at that point in time. And, you know, the one thing that I could still do was drink. And in my mind, you're not going to take away my God-given right to drink. Now, mind you, I wasn't even 21 yet, but, you know, it was my God-given right. And what happened is, you know, as a result of this and my experiences, I started to become aware that there's a direct link between substance abuse and traumatic brain injury. The rates are higher than in the general population. There's a whole host of reasons. And in fact, it was when I was in graduate school, before I actually stop drinking, I decided on a whim, I guess this was maybe divine intervention, that I was going to research substance abuse and brain injury. And that's actually how I became introduced to Dr. Corrigan. Before I knew what NASHA was, or I'd met any of the people on here on this phone, on this meeting, I was reading his research. I wrote a couple papers on it. You know, my professors were like, oh, this is really good papers. Like, this is great stuff, you know, blah, blah, blah. And, you know, so I knew for me that, you know, when I hit that bottom, that my time was up, and that I actually had to reach out and admit I needed help. And it was kind of very similar to the recovery from the brain injury, right? We had to let that guard down and admit we need help. So fast forward, leading that to where it leads me now. You know, I had to, like I said, part of my consequences with the legal system and getting out of incarceration was attending a 28-day rehab where they let me leave to go to work during the day, but I spent the nights and the weekends there. And, you know, it started there with trying to educate people there about brain injury and the links between brain injury and substance abuse. And they didn't care. You know, I would say to judges, I would say things to, you know, prosecutors and you know, the defense attorneys. They would nod their head, but they didn't care, right? They didn't see that link. They didn't see any correlation between the two. So that has kind of been one of my main goals, and one of the things that I've been very blessed and fortunate is to be able to actually now regularly present to different groups of police and correctional officers and explaining and going through the links between substance abuse and traumatic brain injury, and how I wrote down, for me personally, drinking didn't help my brain injury recovery, and brain injury didn't help my drinking. You know, and you could take drinking and substitute it with any other type of substance abuse or even addiction, to be honest with you. You know, Stacia, who's on this call, and I, Stacia Winston, she actually is like the guru of training in Maryland and nationally, especially with a lot of this stuff. You know, we work with an individual who's living with brain injury and co-occurring gambling issues, and he, you know, is in recovery from his gambling issue, and he talks about that, how there's just that natural link, you know, and that one definitely doesn't help the other. So what has happened since then is I actually was able to start a 12-step group that was geared specifically towards individuals with brain injuries. And up until the pandemic, it met every week. It functions as its own standalone meeting. It's been in the directories. I've had numerous people come and want to join us there. It's been really a very unique experience that I think has really done a lot of good and benefited a lot of people, probably me more than anybody else, which has been really cool. I can also tell you that there have been some probation officers who get it now. And they actually have referred clients from out in the community that they also know are living with brain injury to this group. And, you know, I can't tell you like that there's something really powerful. You know, I believe it was Carol who shared earlier talking about that peer relationship. It's kind of the same thing. You know, it really is kind of the same thing in the recovery world, at least, you know, this component of it, the part that I like to advocate for, or the part that really helped me. You know, I will tell you, as far as I am concerned, you know, I don't know if I was an alcoholic before my brain injury. Looking back in hindsight, yeah, I had some tendencies, right? But the brain injury definitely didn't help things, and definitely exacerbated the extent to which it was impacting my life. And you know, there's just so many individuals who are living with this. You know, the statistics are ridiculous if you look at it at all. The prevalence of individuals with brain injury in our criminal justice system and in our substance abuse system. You know, we like to say, you know, usually where there's one, there's going to be a couple other things going on as well. And, you know, I just want to make sure that I'm doing everything that I can to educate others about brain injury and its impact on that. Again, I'm not excusing its behavior, but if we can put the right interventions in place, we can do things a little bit differently, like we could break that cycle, right? And, you know, maybe that person doesn't have to stay in that revolving door, you know, that once they get in that correctional justice system, that the in and out, and the in and the out, the in and out, like maybe there's a way to help them. So, you know, for me, I just, again, you know, I find that the ability to share about this and educate others about this has been really groundbreaking for me, but it also allows, I think, you know, hopefully other people to learn a little bit more about this to hopefully help others as well. So I think I'm going to stop talking now because I'll start rambling, and I, you know, really just appreciate everybody's time. Thank you for ending your day with us. And, you know, I can't thank Eric and Sean enough because they're a really tough act to follow. So thank you, everybody.
Martin, thank you so much for sharing your story. And I just want to echo again, thank you to all three of you, Eric, Sean, and Martin. I've just been, you know, watching the chat as you're talking, and you guys have to take a minute to go through there. You'll find a lot of what you're saying really resonated with people in our audience, from that not being diagnosed and not knowing you're living with a brain injury when it first happens and discovering that later and what that means, to living with behavioral health issues and concerns following brain injury, maybe before, maybe not, dealing with homelessness. I mean, what you all shared is just so enlightening for people. And I think it also just really touched people. So thank you very much. I'm not seeing any specific questions, and boy, is the chat blowing up.
Hey, Judy.
So. Sean,
Judy,
go ahead.
Real quick, go figure that out of all these panelists, the blind guy forgot to describe himself. Yeah, I'm bald headed with a slight beard, with a white shirt and a white background. And for those of you who cannot see me, they say I look like Denzel Washington. Thank you.
I mean, that's absolutely 100% correct, Sean. You do.
I hear the same thing about myself sometimes.
I love it. Okay, I think unless any of you have any additional comments to add, Eric?
I was reading the chat. It was I think her name is Virginia. She said, I miss my former life. I can tell you that, you know, I was the same way, but I can tell you now that you're even better now than you were before. Because when you look at it, we're all stronger than we were at the time of the injury. So I can tell you now that, you know, it's going to take a while sometimes, but you know what? We have to be appreciative of the things we do have. And I can guarantee you are a 10 times better person now because you're probably empathetic. You probably really care about, you know, people. You care about time. You see the world in a different way. So I'm willing to bet you're 1,000 times better today than you were before.
That's great. I'm glad you added to that, Eric. I saw that as well. Other last comments from you all or words of wisdom?
Judy, there's a question in the chat.
Oh, good. I'm glad you're tracking. I'm just seeing fly.
She just, I think it's good to note. She said she was surprised about to learn that traumatic brain injury and alcoholism are connected. Where are these statistics? I thought you might want to address that.
Yeah, and there's other people in this audience who can address that more. Martin, you might be able to share a little bit because I know you train peer specialists in a behavioral health setting, but it's a very high co-occurrence of brain injury and behavioral health. Go ahead, Martin.
Yeah, and I mean, you honestly, like if you even just do a simple Google search, you type in there, you know, brain injury and substance abuse or incarceration and brain injury, you're going to get a ton of things back. And I know Dr. Corrigan has published, you know, going back decades, sorry, Dr. Corrigan, on that topic as well. So, I mean, there's just a ton of stuff out there, and it just, keeps growing and growing. And in fact, people are putting links in the chat right now.
Great, thank you. Cliff, I see that you've put your hand up. You want to jump in?
Yeah. I just wanted to share that as a person with the formal education as a mental health peer specialist, it's been my personal experience that somebody with a TBI has trauma, and therefore it's going to affect your mental health. And it's taken a lot of time for me to educate the mental health community because the TBI was an initial diagnosis, they don't consider it to be a mental health issue. And so that's what I'm trying to educate the mental health community that that you can't have a TBI without having a mental health problem, because your life is full of trauma. And that I even found that people with electric shock treatment have TBI. And we know that there was way too many people receiving electric shock treatment back in the day in the mental health community. And so I think the more that it gets talked about, the more that can take place. And I hope that New York State someday will be included in the states that offer peer support for people with traumatic brain injury, because there's so many people that have TBIs in my community that are not on the waiver, TBI waiver in New York State. If you're not on the waiver in New York State, you don't receive services. And that's another reason why peer support is so necessary, because we can reach out to people who are not receiving services for TBI and share our experiences with independent living skills and behavioral health and stuff like that. And I just hope that anybody who's in the mental health field would open up their mind to the possibility that, you know, it could benefit people with TBI. So thanks a lot.
Thanks, Cliff. There is another question. Do you believe that the issue of intersectionality points to the need for person-centered care? Go ahead, Martin.
Yes. You know, and you know, I don't, Eric and Sean, please feel free to jump in, anybody else too, but you know, again, it personalized and individualized, right? Like this should be the goal in order for it to make meaning for it. You know, there definitely should be personalized, because in my experience, right, you feel, and it wasn't through anything that anybody did on purpose or consciously, but I felt like I was less than what I was. And there was that fear that that was never coming back. And to be honest with you, there are days, there's still some days that 24 years later where I still have those feelings. So, you know, if it's individualized, that again is brought up, and also is too that dealing with that loss and that mourning, and it's not just the same thing being fed to everybody, because you lose part of who you are. You want to feel whole, you know. And for me, I'll tell you, I mean, nothing was as powerful as when those therapists would talk to me about like stuff, not my, you know, range of motion that day, or that, but it was like, you know, hey, tell me about your track career. Hey, what did you do this weekend? And they actually cared, or they were really good at pretending they cared. You know, like that went so much further. And that's what I remember. I don't remember the exercises that I was doing. I don't remember the strategies that they were putting forward. I mean, I'm sure I used them, you know, subconsciously, but those are the things that I remember. And those are the things that made me say, you know what, I'm going to do my best today. This is a reason to keep fighting.
And Martin, I'll say this for myself, because of my newfound knowledge of TBI, I will be seeking, you know, therapy as well for myself, to really gain a perspective of what I missed coming from these past 32 years. And so that question about person-centered therapy was very, very. I'm glad that question was asked, because when I seek out assistance, that is something that you know, I will be seeking. So, you know, like I said, just looking kind of prepared to go through this journey and learning more about TBI myself.
I think too, I appreciate that question, Good seeing you again, Martin. You look good in that suit. But I think a lot of times, professionals, I mean, they have to understand that just because sometimes you have all the knowledge, sometimes it looks different. There's tons of people that I know that, especially in the homeless community, people don't like, a lot of organizations don't like to play fair. Sometimes you have to, it's all about getting the grant money and getting the most money, but it's about what you do with the money, not just collecting the money. There's people on this call that I know, there's people everywhere that they need wraparound services. They need not only the mental health counselor, they also need the rehabilitation people. They need doctors. They need everyone to be on the housing coordinators to be on the same page so people can get the services they deserve. The issue was that I had to wait in line for these services to get a place to stay. I was on a waiting list for 50 years. Then, but I can go in and get the food pantry, but I live in a car. So what am I going to do with this milk? So it was like people were just doing what they thought needed to be done. And the issue was that people are not wrapping their arms around these people, understanding that, like you said, it's co-occurring. It's like an onion, like my brain injury led to my depression, which led to me getting fired, which led to me being homeless, which led me trying to kill myself. So it was like, without the people actually helping me, and they call it Maslow's hierarchy. If I can't get a house, the bullets is going to be flying and I'm not going to feel safe. So I think that people need to learn how to have strategic partners, play fair, share the money, because the person that's losing is the consumer, it's the partner, it's the us. We're the ones that's losing off of all of this. I think I know it all. So, yeah.
I do want to ask this one last question that I see, and we're 1 minute to time. And this might actually be something that people could put in the chat too, but a person asked, how do you educate the criminal justice system when you know someone is incarcerated with a brain injury? What is the first step for a family to do to help their family member? And I asked that specifically because Eric, I know you have experience, and Martin, and I know we have some people in the audience with experience. So if you could please chime in chat, or Martin or Eric, if you want to jump in.
I'll be real brief. Sometimes once they get in, it's difficult because, everyone, as the system itself is like, oh, look at Martin, he's back, he's trying to get out of here. Like that's kind of how they play it. So the thing about it would be to try to reverse engineer this to where if it's suspected that a person has a TBI or some type of disability, that they get, judged amongst their peers. Like it's different, up here in Missouri, they have mental health court. And they just separate the two because this person has an ongoing history of this. But once they get in there with the general population, it's real hard to get them out because every lawyer is trying to, use whatever they can. So I think that we need to fight it before people get there. So when they take a TBI screen or something, when they go a physical, whatever, and it's noted, now we get them out of there into another type of location.
And I think, just to piggyback on what Eric was saying is the most important thing is you need to have that official diagnosis. You need to have that official, you need to have something that states and proves that the individual has that brain injury, and if you don't have that, that's where you need a really strong advocate and you need somebody who gets it, right? Because if not, they're, in trouble. Stacia just put in the chat, we've worked with, both of us have worked with multiple individuals who we were able to get out of incarceration with the condition that they attend, they go to one of our providers, but it was, a lot of hard work on the front end to prove that this individual has a brain injury. Their brain injury is impacting their well-being, their behavior, and everything else. And if we get them the right interventions, guess what? They get out of this system and they can get rehabilitated, which is the whole point of it, right?
Great points. Excellent, excellent session. I hate to cut off the discussion, but we are out of time. So Sean, Eric, and Martin, thank you again so much for sharing your stories and being willing to chat afterwards. With that, I would like to bring Elizabeth up to close us out.
Well, thank you, Judy. Wow, what an afternoon this has been. We started off with an education on the Area Agency on Aging or the Administration on Aging with Edwin Walker, and then John Corrigan talking about what's going on in Ohio. I thought the employment session was really great with Amy, Eileen, and Jill. And then, of course, these last two sessions were really powerful with peer support and intersectionality. So before everybody jumps off, I want you all to hang tight because Terry needs to do some real-time evaluation questions. But let me just, quickly thank Jill Jacobs, our administrator, as well as Edwin Walker from the Administration for Community Living, and Sean Calloway for sharing your story. For the sake of time, I am going to go ahead and turn it over to Terry. And thank you very much to the TBI TARC. We couldn't have done this without you guys.
Thank you, Elizabeth. And I second what Elizabeth said. This was wonderful. I learned so much, and it was a great event. We have a few questions. It says 7, but it's actually 6. And we just want to get some feedback on how today went and ways to improve it. We're really always looking to improve what we do. So if you can, you should be able to see the poll right now. If you can go ahead and answer the questions. And while people are doing that, I just want to let everyone know, is it up, Shaska? Oh, there it goes. Okay.
Yeah, just give it a sec.
And if you have any questions on how we might improve the TBI TARC webinars and events like this that we supported the Administration for Community Living with, or if you have any ideas or requests for future webinar topics, please send us a note at tbitarc@hsri.org. As always, you can reach out to us at this email address for future topics, or if you're looking for information, we are a technical assistance and resource center. Or if you want to connect with any other speakers, please do reach out to us. We will be posting the recording on the Administration for Community Living website, and once that's available, we will email you and let you know that it's up. So it will be a recording, it will have the captioning, so that will be available hopefully in a few weeks. And as always, please reach out to us. We actually finished ahead of time, but we want to give some more time for you all to complete the evaluation questions, because they are very helpful to us and we do look at them. I want to thank Maria, Judy for leading us in the discussions, and Shaska for doing all the logistical and making sure things are working, and Vivian behind the scene. And I want to thank all the presenters. Thank you so much for giving your time. I know 4 hours is a long time of your day. And especially I want to thank the members of the TBI Advisory and Leadership Group for your involvement in this event. And we always look forward to hearing from all of you. And thank you for all the participants for making time for us. And we're doing pretty good. We're at 84%. And that's it. Thank you. And I hope you all enjoy the event. Looks like answers are coming in and we're done. Thank you, everyone. Have a good day.